We're going into the breakout sessions. We're having 4 breakout groups. I believe everyone has gotten a group. Kindly indicate if you haven't gotten a group yet. Okay, nobody, as expected. Thank you. So, of course, all of these will still be displayed on the screen, but I'll just read them out. For Group 1, District Governor Femi Adenekon will be the team lead. And the question or the topic they're going to be looking at is develop advocacy goals and objectives for reducing maternal and child deaths. Of course, you look at maternal health and child health challenges as well. Group 2, which will be led by PDG Dana Jawara, develop an advocacy action plan to create family health department in Ekiti, Gombe, and Nasarawa states. Group 3, which will be led by DG Kayode Ololagba, is develop an advocacy action plan to increase family planning uptake in Ekiti, Nasarawa, and Gombe states. And then Group 4, we're going to complete that of Group 4 in a bit. Then Group 4, the frequent causes of maternal deaths. Group 4 will be led by DG Wole Kukoyi. The frequent causes of maternal deaths: PPH, eclampsia, that's as well as pre-eclampsia, sepsis, incomplete abortions. Now, so for these causes, you develop an advocacy plan to sensitize communities and create awareness on the causes and prevention. We'll leave this on the screen. That of 4 is not yet complete. We'll complete it.
Good morning, everybody. I am standing in for Group 1, the Elders Group. And our group is to develop goal and objective to the reduction of maternal mortality and child as well, and using the challenges. We all know we have all these delays at the facility, at the community, at home, and then we have another delay which has to do with access to the health facility. So our goal is to achieve a reduction in maternal and child mortality rates by 25%, 2030, to enhance quality maternal health care, access, education, and community engagement. We have another goal, again, to strengthen community participation and engagement using the local structure through enlightenment campaigns. Then the last one is to integrate maternal and health information system by 2030. Our objectives: to increase access to quality maternal and health care services in underserved communities by 2030. We have another one: to ensure availability of skilled, trained healthcare professionals in our health centers. To enhance education and awareness by implementing education programs focusing on maternal and neonatal child health. To strengthen healthcare system to improve supply chain management for essential medicine and other medical supplies. To establish a data management system to monitor maternal and child health indicators. to engage with community-based initiative programs involving the local leaders, like the religious and traditional community as well, and other organizations in promoting health practices that has to do with maternal and neonatal child health. To involve TBAs and community structures such as COPs and CHIPs in the reduction of maternal deaths by ensuring adequate training, referrals, and data collection at community level. To engage with private sector to finance and support programs around maternal and neonatal child health. To strengthen MPDSR program at all levels. If our MPDSR program is being strengthened, I am sure we shall reduce maternal mortality in Nigeria. So let government see that as a priority. Then to develop a legal framework to enable compliance by healthcare providers. To conduct regular monitoring and evaluation to enhance the compliance at all levels and make program adjustment at when due. Thank you very much. That is for Group 1.
Comments, questions, just show of hand. I'll bring the mic to you. Comments, questions, just indicate with your hand and I'll bring the mic to you. Okay, Prof wants to make a comment.
I'm not sure whether I had to improve effective family planning.
Okay.
Because, as I said at the group level, if you do effective family planning, you can reduce maternal mortality by 30%. I think that should be a key point.
Okay.
Thank you very much, Prof. Questions, comments? Let me borrow PDG Hassan's language. Contradictions? Oh, disagreements. Thank you, sir. Disagreements? Any?
Write this, Prof, comment.
Okay, please, let's appreciate Group 1. Thank you very much.
Thank you, Elders Forum, for giving me the opportunity to present on your behalf. Thank you.
Thank you very much, representative of Elders Forum. On behalf of the good people of Group 2, I've been asked to call up Mr. James Sunday for their presentation. Please, let's appreciate him.
Good morning, everyone. The task for Group 2 is to develop an advocacy action plan to create family health departments in the FCT, Ekiti, Nasarawa, and Gombe states. We, as a group, we broke down this goal into objectives. Our objective number 1 is to advocate for creation of family health departments in FCT and the 3 states, and to secure government and stakeholders' support and commitment in the 3 states and the FCT. Those are our 2 main objectives. Now, our activity number 1 as part of our advocacy action plan is to carry out a situation analysis. We feel that there is a need to understand the problem before we delve into the actual advocacy or doing any form of planning. So we need to really understand why. You know, why is it that we don't have a family health department across those 3 states and the FCT? we need to understand and establish this fact clearly. So we're going to carry out a situation analysis to help us understand this. We're also going to identify, challenges in each of the states and then propose possible solutions on how to go about creating, the family health department across the 3 states and the Federal Capital Territory. As part of this effort, our activity number 2 is to do the actual advocacy planning, which we feel is very critical and fundamental. And in doing the actual advocacy planning, we're going to first and foremost identify our target audience, because knowing our target audience is actually critical to the framing of our messaging and all of that, and that we feel is important. So we're going to identify our target audience. Under the advocacy planning, we are equally going to constitute, the advocacy team. We feel this is also very pivotal, and the composition of this advocacy team will be comprising key experts, with the powers to influence decisions. These experts are going to form the team, the high-level team that will be carrying out our advocacy effort. And some of these key experts will include stakeholders, from the Federal Ministry of Health, the UN groups. We're going to include Rotary, as much as possible. We're going to include SOGON, civil society, relevant civil society organizations, and even the community leaders who we feel are gatekeepers and are able to equally influence, opinion and decision at that level. Our next activity, as part of this effort, is the stakeholders mapping. In mapping our stakeholders, we're going to identify our primary targets. And our primary targets for this particular effort are actually the top government officials and the governor. They are our primary targets, because this particular group of audience are actually the ones who are responsible, or all of this, anything that has to do with setting up of that very particular department falls within, their own responsibilities. So they will be our primary target for our advocacy efforts. And our secondary targets are other key influencers and pressure groups that I mentioned earlier, like the CSOs, the media, the traditional leaders, and a host of other key influencers that will be able to equally influence government-level decisions. Then we have the state champions. We're going to reach out to opinion leaders, at community level who serve as our state champions, and they will also be part of those we are reaching out, with our advocacy effort, because they are also critical in this entire process. Moving away from this, we have our key messaging. And talking about our key messaging, we agree that since we are dealing with government stakeholders, with donors, and a host of other critical partners, there's a need for us to actually present some key data and statistics around, landscape and around the need to have that department created in each of those states and the FCT. And that is very important. And all of these data will be able to actually come via fact sheets. We can have short video documentaries that will help us convey some of this key data and messaging that will clearly that will aptly capture, some of those key statistics around the burden of maternal infant mortality in the States and why it is critical to have that department created. So the data will speak to all of that. Then we, as part of our messaging, there's a need for us to justify why we actually need that department created. And with that justification, we're going to develop a rationale, which we're going to present, and that can come through our one-on-one engagement and even via presentations, depending on the stakeholder we're meeting, either the top government officials or the governor himself. And then we are also going to develop our strategies and suggest some possible solutions on how this department can be created, basically. Our fifth activity is to actually develop our advocacy strategy, to kind of come up with our order of advocacy. Topmost is those top government officials. We're going to meet with them, the ES, the PAMSEC, and a host of other government officials within the State Ministry of Health. We're going to reach out to them first, to help us gather some relevant information that we will need to even engage the governor. Because we need to get their buy-in. If we're able to get their buy-in, we're able to get their commitment, because we understand that the governor himself, might not even take a unilateral action and may need to engage with them further, to make some critical decisions. So if we have already reached out to them, it is an easy sale for our advocacy effort, to fly. So when we're done reaching out to the top government officials in the ministry, we also have a conversation with the governor. And considering the fact that we equally have the FCT, the governor, and then the minister of the Federal Capital Territory also. Very important. I think I missed out that part from my initial explanations. So we're going to engage equally with the governor. And after engaging with the governor, then we're going to reach out to other relevant stakeholders and champions, including civil societies, UN groups, and other relevant stakeholders we feel are important to our advocacy efforts. And we discussed the frequency. How often do we intend to carry out this advocacy effort? And we said, there's a need for us to do it on a quarterly basis. It's a continuous process, but we've decided that, it's going to be on a quarterly basis, or when the need arises, because if there is a need in between, we must not wait for an entire quarter before we actually proceed with the advocacy effort and engage. So we are monitoring the situation, and that takes us to the next point, which is monitoring and evaluation. So if we're done with all of this, there's continuous monitoring. We continue to engage, even beyond the official engagement we feel we'll be doing. There's a need to also be reaching out in the background, to be getting the pulse of the government, what is happening, what conversations are happening. We need to establish those kind of relationships and linkages to enable us understand what is happening. We'll be reviewing, we'll be monitoring, we'll be reviewing, and then if there is a need for us to actually launch another campaign or another advocacy effort, we can re-strategize as well to see how we can drive this home. So this is our presentation, and thank you for your time.
Okay, I can see one hand up there. Thank you very much, Group 2, for the presentation.
That's my group. We equally omitted to add, when we get to the FCT, we are not going to see Barrister Wike. Rather, we go for Secretary for Health, the mandate secretary, first and foremost, before we can now spread our visiting. Thank you very much.
Thank you very much for the addendum. Any question, comments? Okay.
Thank you very much, Group 2, for that presentation. Mine is on the establishment of Department of Family Health in the states. I want to believe that there are states that are already implementing activities in that respect in their states. They may not carry the name Department of Family Health. So if we are to open up another one, won't that be a form of duplication? Rather than for us to probably identify the states where there are no existing activities of family health currently ongoing, for them to establish one. That's my point.
Okay, so other group members will also have opportunity to contribute, but if you listen from the beginning, I said we're going to do a situation analysis. While doing the situation analysis, we're equally going to establish if there is a need for it. So if there is an existing agency, carrying out performing related responsibility, our situation analysis will actually bring that to 4. It will bring that to 4, and that will actually inform our next steps, in our advocacy planning effort. So our situation analysis takes care of all of that. So we'll establish if we actually need to proceed ahead with pushing for that department, depending on what we see on ground from our situation analysis.
Any more question, comments? You want Prof? No, before you clap, Prof wants to make a comment.
Okay.
Thank you very much. I think I'm also in that group. Just to say that I think the governor should be the last person to be seen because you start from bottom up. For example, if you get to the PAMSEC and you achieve your aim, you don't need to go and see the governor. So the governor should be the last to be seen. Thank you.
Let's put our hands together and appreciate Group 2. Thank you very much, sir. So on behalf of the great people of Group 3, I have the honor and privilege to call up Dr. Mrs. Busayo Sarah Ige.
Good afternoon, everyone. This is Group 3 presentation. We are to develop an advocacy action plan to increase family planning uptake in Ekiti, Nasarawa, Gombe, and FCT. Actually, before this topic can come up, we discovered that there is a problem. Peradventure, maybe there is low uptake of family planning. And that is why we have to come about the increase in family planning uptake. So there are steps that we have to follow. There should be problem identification. Because if you are not able to identify the problem that is causing the low uptake, you will not be able to solve the problem. So the first thing is problem identification. The problem identified are cultural/religious factors. We are able to see that family planning uptake are being affected by this cultural problem. You know, when you get to some communities, some people will be telling you that if you take family planning, your stomach will be swollen. Some people will be saying things will be moving around your body. Different kinds of belief. Some people even believe that it's not ethical to take family planning. And when we come to the religious aspects now, you even see some pastor preaching against family planning. That when you take family planning, it can make you to become promiscuous. So that is one of the problems. Then socioeconomic factors. Poverty is part of it. When you are to go for family planning and you don't even have money to take bike to that facility. Some people will say, I've not eaten. How will I go and take family planning? I don't need it. I need food. Those are the things we face at the community level. Then ignorance. Recently, I was speaking with somebody. She said that those people that are still giving birth to children doesn't need family planning. She believed that it is when you stop
when you are not ready to have any child again, when you stop bearing children, that you can go for family planning. She is not aware of spacing. So that is part of ignorance. And I met with a man sometimes ago who said that, why did your wife didn't do family planning? She said that she doesn't need it. She's still breastfeeding. So ignorance is what we call a disease. So when people did not know what they're supposed to do, it can affect the uptake of family planning. Providers bias. You know, at times providers are biased against the uptake of family planning. In fact, the attitude of providers at times can send away people from taking family planning. Most especially the young adolescent. When you see somebody that you know, ethically you are not supposed to challenge her that why are you taking this step. For example, a teenager coming to you that she needs family planning and you are saying, you have started having boyfriend, you have started this, you have started that, I will report you to your mommy. So as a result of that, that person will not come back to you to take family planning. So that is part of provider bias. There are times provider may think that as I'm looking at you, mommy, you will like injectables. You will benefit without counseling you, without asking you questions. Then systemic factors such as technical know-how. You know, we are talking about task shifting and task sharing now. But when there is nobody to task shift the task, there will be problem. Then when those people that we want to shift to, that we want to task shift to, are not available or they are not knowledgeable, it will be very, very difficult. The accessibility, part of systemic problem is accessibility to health facility. When the health facility is not accessible to women, those people that want to take family planning, it may affect the uptake. Then one non-availability of manpower. We all know the problem of Nigeria presently, the exodus of health workers. So when there is no, those people, those people that are knowledgeable, most especially on lack contraceptive, it may give problem. At times when they get to the facilities and they don't meet somebody that can offer them that family planning, they go back home. So next time, they will not come back again. Then equipment, commodities and consumables. When these are not available at the facility level, it can send the patient away, the clients away. Because when you come today and you ask me to come tomorrow, I've wasted the transportation money already. So I won't come tomorrow again to assess that family planning. Then low awareness. Like I told you, some people have erroneous belief about family planning. Some people don't even know that family planning is free. Recently, we did community outreach. Some people were surprised to hear that we are not collecting a penny. So when they discovered that we are not collecting money, it motivated them to come and take it. Then poor male involvement and spousal support. I've seen situations where we face a lot with spouses telling their wives that they should not go for family planning. I still talked with somebody recently who said that my wife did not need it, that we are using safe period. I told him that safe period can fail. So you have to take family planning. The wife was looking at his face just to give her go ahead. She said, he will not agree. And if I force myself to do it now, by the time I get back home, I will face a lot of problems. So, mommy, just leave me. When he agrees, I will come. Then the goal of what we are doing is to sensitize the community members on the availability of contraceptive at the health facilities and to increase family planning uptake by 10% annually over the next 3 years. So this is our advocacy plan. We first of all have to do the state state and community stakeholders mapping. We need to enlist the stakeholders that we can consult, the influence, those people that can influence the people at the community level. We have to compile their list, and at the state level, we have to do stakeholders mapping. Those people like Commissioner for Health, Commissioner for Information, Commissioner for Education, PS, Director Public Health, Director Women Affairs, all these and developmental partners. We have to have a meeting, workshop, advocacy meeting with them, so that they will know what we are going to do about family planning. So we, at the same time, we have advocacy meeting with state, local government stakeholders as well. Because when you want to enter any community, you don't visit the stakeholder. You didn't tell them what you are about to do. You will not be successful because they won't allow you. Even if they allow you, the community people will not listen to you. But the moment they see that you have already met with their leaders and they give you go ahead, then you are free. You have been able to make your way to some extent. Then systemic approach through domestication of family planning policy. This should be done at state level. We have national family planning policy, which has to be domesticated at state level. Then training of health workers. Like I told us, we have to be doing training and retraining of health workers, because some are retiring and some are traveling out, some are giving voluntary retirement. So as a result of this, we have to fill the gap. We have to train the health workers, most especially on long-acting contraceptive, reversible contraceptive, because it is not something that anybody can do. Ordinarily, when we are talking about oral pills, injectables, anybody, you can do on-the-job training. Anybody can do it. But when we are talking about lack providers, they need to be trained because it has to be done by skilled people. So then approach to clients is part of it. If you don't train health workers about the client approach, they may mess it up. Because most especially the young adolescent, either you know the person or you don't know the person. She has the right to take her decision. And you have to dispel the misconception that anybody that does a family planning will just become promiscuous. You have to dispel that in their mind, and so that they will be able to do it the way they're supposed to do it. Then allocation and release of fund. It is one thing to allocate fund for family planning programs. It's another thing to release the fund. And it's other thing to make use of that release fund. So all those things has to work together. Then there should be procurement of family planning commodities and consumables. So utilization of the release fund, like I said, then it is the responsibility of the state government and the partners to help in the last mile distribution. You know, federal government are supporting, are providing consumable and commodities. But it is one thing to get it to the state. If the state is keeping it inside the store, it will not do the work that is supposed to do. So there should be last mile distribution. That is, you must get it to the delivery point, the service delivery point. Then the community activities. We supposed to do community dialogue where we meet with the community level. We meet with the World Development Committee leaders, the women of childbearing age, market women leaders, and the husband and wives. It cut across many people that will be in that community dialogue, and we educate them on family planning. There we can ask them what they are doing, their knowledge about family planning. Then you take them from known to unknown. Then enrich and outreach programs. If this client refuses to visit hospital or visit those areas that are far, you can take it to their doorstep at no cost. So they will be forced to take the family planning. Then sensitization activities on family planning uptake through media engagement, market rallies, roadshow, and so on. So involvement of law enforcement agency. This can be done by involving them in our stakeholder meeting in decision making. So we need, when we are doing this, we need to make evaluation. Because if you are doing your work and you did not evaluate, you will not know maybe you are progressing or you are not progressing. So monthly data collation. When you are collecting your data, you know the local government that is doing well, you know the local government that is not doing well, you will ask why are they not doing well, and that will prompt you to take the next action. Then supportive supervision. When you meet them at service delivery point, you will know maybe this provider are doing well, maybe they still have commodity or they are stock out, or if there is any problem they are facing, when you identify it, then you will know how to solve the problem. Reward/award for the best performing LGA and state. At LGA level, the best reporting LGA. It may be an appreciation word, or you can give incentive anyhow. And at the national level, a state that is doing well can be equally appreciated. Thank you very much.
Thank you very much, Group 3. I can see one hand up here. That hand came up first. I'll come to you, ma.
Thank you very much, Group 3, for your presentation. However, I'm confused along the line. Is it an advocacy plan or a narrative? I'm confused because I didn't see the advocacy action plan. What are those plans that you have? Because we didn't see what and what you will do. We're looking at most of the things. And I don't know if you can give us the action plans. What are those plans? Maybe you go back and redo it as a group. My personal opinion anyway. But it looks more of a narrative and a personalized presentation. Yes, now it looks like more of one particular state, but you are speaking for 3 states. From what they gave you is to increase access, and most of the activities does not speak how you can increase allocation from what the question is, if I'm correct. Thank you.
Hello, ma. Don't forget, we are to work on the uptake of family planning. Develop an advocacy action plan to increase family planning uptake. We are going to increase family planning uptake. So there are some things we need to do. Advocacy plan is part of it. But when you are going to increase family planning uptake, there are some actions that need to be that you need to take so that it will increase the uptake. So the example that I'm making may be personal, but it is equally applicable to other states. Other states do experience that examples.
Thank you very much.
Thank you, Group 3. Activities that involve critical thinking is not always easy. So I just want to say well done.
Thank you.
My name is Queen Evelyn Abanyam. I work with her promotion division. I just come to give to my boss. The first observation I want to point out is based on action plan. Taking a right from what the last speaker spoke, a lot of things are here, but just like that mixed up. Then part of your action plan that is supposed to be conspicuous is development of advocacy kits. There is no meetings for stakeholders to come together, and you can never carry advocacy without data to show what is happening to anywhere you are going, unless I didn't see it well. And there should be a plan for revisit. Part of the reasons why some of our advocacies are not fruitful is that we are seeing it as a one-off thing. Advocacy is continuous. By the time you carry your advocacy visit, you should be able to follow up. And even before you go, there should be underground meetings of where you can make use of advocacy tools like lobby, looking for who knows somebody before you get to the last person. And finally, I think I love your plan to evaluate what has happened and know how to replan. Thank you, and a good work.
Thank you very much for your contribution. I think I stated it here that we are going to do advocacy meeting with the state and LGA stakeholders. And after that, we do advocacy visit again. But that lobbying you are talking about can be added to it. Thank you.
Thank you very much, Group 3. Please, a round of applause for Group 3. We'll have Group 4 now. You didn't give me the name of the person presenting, so I'll just leave it that way. Group 4. I'll take it off. Group 4. Okay, somebody's coming.
So good afternoon once more. The last speaker took 1 hour, I will take 2 hours. So I'm also speaking for the elders in the house. Please come and support me because you answer all the questions. So I'm speaking for Group 4. Our topic is Advocacy Action Plan to Sensitize Community on Causes of Maternal Death. So who are the advocates? We have the policy makers. We are looking at the government at the community level. We are looking at the professional bodies at the community level, private practitioners at the community, and then the local politicians and legislators at the community level. So we also look at the media, the local media and the community leaders, where we have the religious leaders, traditional rulers, women leaders, youth leaders. We have the IPCAs that we call the interpersonal communication agents that interact with the male counterpart at the community. Most of the times they meet them at the majelisas where they play draft and the rest of them. And we also look at the TBAs at the community level. So the plan is for us to sensitize the community leaders, the traditional leaders, on how to take ownership of programs at the community level. Because most of the times we discover that they are the pushback to all programs and that leads to maternal death at the community. So by the time we sensitize them and tell them what are the key, what they need to do to involve themselves in preventing maternal death, we believe that it will go a long way so that they can be able to talk about it at the community, at the churches, and at the mosques. So we also need to sensitize the local politicians to be able to take ownership of their community. Some of them went to the legislators or the government because of the community, but they are not helping the community. So they need to come back and take ownership. We also use the IPC agents, like I said, and also sensitize professional bodies or Ministry of Health that regulate private schools at the community. We discovered that we have a lot of quack private schools that are operating and then graduating students that are becoming users to the community. So we need to sensitize them. We also need to advocate for review of school curriculum, but this cannot be done at the community level. So we also need to sensitize local social influencers. We have people at the community that organize all these local dramas. They sing songs in the community. So we want to sensitize them so that by the time they are doing all these things, they should be able to put messages that talks about maternal death. So what are some of the messages that need to be included in the advocacy brief? We have messages that talks about prevention, messages that tell us what's local belief and taboos at the community. We also need to give them data that will also speak to the level of maternal death at the community. And then we also need messages that talks about early action to prevent complications, and also early referral to the facility whenever they find out that there are such things. And the local media will be able to give us jingles that people will listen to. Thank you.
She actually didn't take the 2 hours. I think she deserves another round of applause. Okay. Questions, comments? Okay, is it because she said she used 2 hours and then she didn't use Prof?
Thank you very much for a good presentation. Did I see anything about Ward Development Committee engagement in this presentation? Because if you are looking at community MPCDS, for example, there's no way you can escape engagement with Ward Development Committee, because they are the key focal people to do verbal social autopsy.
Thank you, sir.
Thank you very much, Prof.
We include that. It's a comment.
So they will include it. Any other questions, comments? Okay, small one.
Just for us to learn. Thank you. It's not really much comment. Just want to talk about just a simple nomenclature for tomorrow. Okay. The group of people you identify, you say advocates. Your advocates should be group of people you want to carry the advocates with. So these are your target audience.
Yes.
People you want to meet.
Okay.
They're not actually the advocates.
All right.
Thank you.
I think Group 4 deserves another round of applause. Thank you, thank you, thank you, thank you, thank you very much. We'll be going to the next plenary session. We'll be going to the next plenary session, and this is tagged Funding Strategies for Maternal and Child Health Advocacy. And in this presentation, insurance for deliveries will be looked at, transportation for attendance for ANC will be looked at, private sector support, and a host of all other issues. This presentation was supposed to be taken by the Director General of the National Health Insurance Authority, but his technical assistant is here in the person of Dr. Nenaya Kalu-Ume, and she'll be taking the presentation. Please let's put our hands together for her as she comes up to mount the podium. Please let's keep clapping till she takes the mic.
Thank you very much. Excellent pronunciation, by the way. Good afternoon, everyone. And let me just say it's been a pleasure and privilege to be here. I actually listened on Group 3's work, and the range of the discussion was really very interesting. And sometimes when you work at the policy level, you're a bit removed from what is really happening at the communities, and seeing those action plans being developed, I think you all deserve a round of applause. Please clap for yourselves. It's really, 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 really interesting. So, okay. Thank you. Okay, great. So, I'm going to be talking about financing strategies for maternal and child health. Advocacy, yes, we talked about advocacy. It's still included. But I'm going to be talking about this from NHIA's perspective. Now, I'm sure we are all familiar with the National Health Insurance Authority. We used to be known as the National Health Insurance Scheme up until 2022. That was when the NHIA Act was now passed into law, and that repealed the NHIS Act previously. Now, the signing into law of the NHIA Act did several things. It changed the name of the organization. That was one. It also made provision for mandatory health insurance in sections 3 and 14. And then it also introduced the Vulnerable Group Fund, which is supposed to finance care for vulnerable Nigerians. So there were so many changes that came with the NHIA Act in 2022. And so what I'm going to be doing in this presentation is to be giving you information about NHIA that will be useful for advocacy. I'm going to be aligning what we do at NHIA with health promotion, with advocacy and maternal health, and also tell you a bit about what we have been doing when it comes to maternal health. So we'll go on to the next slide. Okay, I have this. Great. So NHIA, we are under the Ministry of Health, and therefore we must align with the health sector strategic blueprint. And I'm sure, I don't know if you're familiar with this, but I can quickly run through it. Now, for the health sector, the goal is to save lives. We want to reduce both physical and financial pain, and we want to produce health for all Nigerians. And then, so what we want to do is to reduce morbidity and mortality, make sure that nobody dies, especially women who are pregnant or in labor or about to deliver and so on. And so we also want to reduce out-of-pocket expenditure. This is important for us at NHIA because we are concerned about financial access. And so under this, we have the pillars, 4 pillars: effective governance, efficient, equitable, and quality health systems, unlocking the value chain, and improving health security for all Nigerians. For us at NHIA, we are really concerned about pillars 1 and 2. Effective governance. How do we ensure that we are strengthened as regulators? Because in the health insurance industry, you have so many stakeholders. We have about 80 health maintenance organizations. Every single state and the FCT, they all have their health insurance agencies as well. So these are stakeholders. Then you have the enrollees or beneficiaries who are also stakeholders. You also have partners who are working in the health insurance space. And then NHIA, with the new law, the 2022 law, our roles have been expanded, not just to implement health insurance, but we are also promoters of health insurance. It's very clearly stated in the law. NHIA should promote health insurance, we should regulate health insurance, whether public or private schemes, and we should integrate all those health insurance schemes in Nigeria. So promotion is a big deal for us. I want to increase our accountability and the participation of stakeholders within the health insurance space. We want Nigerian citizens to know what we are doing, which is one of the reasons why we're here. And like I said, strengthen our regulatory capacity so that we can hold all the stakeholders accountable. They should do what they should do to the highest standards of service provision. We want to ensure that there are efficient and equitable systems. If you look at the first one under there, if it's clear, we want to drive health promotion, not just from the health sector perspective, but with other sectors that are also involved: education, agriculture, and so on, environment. We also want to strengthen prevention. We do not want to wait until people come to the hospital and then they are sick. Even before they come, we are beginning to integrate that, make sure that people know what they should do to take care of themselves, to reduce the burdens on the hospitals. We want to improve the quality of care. And then we also want to ensure that there's affordability. People can actually pay or afford to go to the hospitals, because that's a major barrier, especially when it comes to maternal health care. The other ones, unlocking the value chain and health security, are also part of the health sector strategic blueprint. And then you have the enablers at the bottom: data and digitalization, financing, and culture and talent within the MDAs. I think it's important to state that the mechanism for, or the approach for implementing this plan is the sector-wide approach, which you might have heard about. What that essentially means is that as a government, as a country, with all the stakeholders, we are going to concentrate all our efforts on national priorities. We're going to pool our funds and then face those priorities and tackle them. And the good thing is that maternal health is one of those priorities. So under SWAP, there are 4 principles. You have to have one plan. Okay, you have to have one plan under SWAP. So this is the plan for everybody in Nigeria when it comes to health. And for this plan, we're going to have one budget. Everybody pulls their funds together, the donors and everybody, and then we have one report. At the end of the day, we're not quoting different sources to say maternal mortality, this rate is quoted by WHO, the Federal Ministry of Health has its own rate. Everybody, no, we have one particular report that says this is where we are with respect to maternal mortality or child mortality in Nigeria. And then we have one conversation, regular meetings, regular reviews where everybody is open and transparent and we say what we are all doing, okay? Yes, so drawing on that at NHIA, we also have articulated our own pillars, which are very similar. Number 1 for us is coverage. We want to ensure that we expand coverage to all Nigerians. Remember that I said health insurance is now mandatory in the law. Implementing it is where the work is. Because when you say it's mandatory, it's compulsory for everybody, it means if somebody tells you he doesn't have money, you must still find a way to make sure he's not left out. So that means that those who can afford to pay should pay or be compelled to pay. And then those who cannot afford to pay should be paid for. Then comes the question, how do you now identify who is able to pay and who is not able to pay? Because if you ask the average Nigerian on the street, they will tell you they are all vulnerable and they cannot afford it. So it's not something we can do on our own, but those conversations have started with the relevant authorities or agencies to see how we can even identify people. The national identity number is now a requirement for registration all over the country, including for the NHIA as well. So that is ongoing. The second one under coverage is promoting positive perception and trust in insurance as a means of financial protection. I want to commend Group 3, their presentation. They gave a lot of examples, the way people perceive health sector interventions with some degree of skepticism or apathy sometimes. And insurance is one of those things. You tell somebody you need to pay for health insurance, and says, why? Am I sick? God forbid bad thing. You need to wait till you're sick. But people insure their cars. So it's not really an acceptable culture yet. It hasn't really permeated, but it's something that we need to begin to do a lot of advocacy and sensitization about to improve the uptake. In some states, the word insurance is almost like a taboo. And so you have some state health insurance agencies being called state contributory health schemes. So the language is modified to make it more acceptable. Work is being done to promote that public trust, that it works. Yes, there are hiccups, sometimes there are delays, but it works. So we're working on that. And then under equity, trying to make sure that whether you are rich or you are poor, whether you are living in the rural areas or the urban areas, that health insurance gets to you. And what are we doing there? We're trying to strengthen what we call the Basic Healthcare Provision Fund. It's been working for a couple of years, and we're still working to make sure that we operationalize it and it reaches every nook and cranny of the country. And then also, like I mentioned, the NHIA Act introduced the Vulnerable Group Fund. So that is also being designed to prioritize equity and the most vulnerable within the population. I would also talk a little bit about that much later on in the presentation. Now for quality of care, for us this is a really big deal because this is where a lot of work needs to be done. NHIA does not directly provide care. We are more of a financier or payer. So what we do is to provide the care through facilities. And so we have to monitor those facilities to make sure that they provide that care. We have to also incentivize them using strategic levers. If you don't give good quality, your money may be deducted, you may even not be paid, and so many other things. We have our operational guidelines. There are rules to be followed. There are sanctions that can be meted out. So we are improving the quality of care by implementing payment models. There are models where you are not even paid until you have delivered the quality care, and that has been verified before you are paid. So various models have been used to incentivize health workers to improve quality. And also we have commissioned actuarial studies to review the costing of the benefit package. For market efficiency, the bigger the risk pool, and when I say risk pool, you pool in health insurance, you pool risks and you pool funds. You want a basket of funds so that whoever is sick, you pay out of those funds and it's not depleted at once. And that pool of funds lasts longer if more people who are healthy actually register with the health insurance. If everybody is sick, everybody drains the pool. So you want to foster effective risk pools so that you have sustainable health insurance markets, which means everybody, whether you need it or not, you should register for health insurance. And then lastly, we want to make sure that the private sector is really carried along. Already we're doing that, but we want to scale that up and make sure that it's beneficial for everyone. And what are the enablers? We want to drive citizen-centered engagement, which is what we're doing, and then want to use data and technology to improve the reach and the quality, and want to optimize organizational health and structure. Okay? Right, so when it comes to, the Vulnerable Group Fund, like I mentioned earlier, is established by Section 25 of the National Health Insurance Authority Act. And now the Vulnerable Group Fund is like expanding the BHCPF, because the BHCPF is now subsumed under the Vulnerable Group Fund. But there are also other sources of funding for the Vulnerable Group Fund. We have provision for special intervention funds allocated by the government, maybe for particular vulnerable people or interventions, maybe for maternal care. We have money that should accrue to the Vulnerable Group Fund because there's room for investments by the council. Now we don't have a governing council, so the minister is the council. We also have room for grants, donations, gifts, and other sources as approved by the council. So the law has made provision for this. What remains is for the advocacy and for the release by the government to make these funds available. Now, sometimes there's this belief that, oh, the money is there with NHIE. There's no money with NHIE. There's provision for it in the law. A lot of the money that comes in is people's contributions from the formal sector and other programs, and that money is pulled together to pay providers. Now, some other funds comes in, like for the Basic Healthcare Provision Fund, is coming directly from the government, and it's not just the NHIA gateway. It's also the NPA-CDA gateway and the Emergency Treatment Gateway. So those funds are distributed, and then we pay through the state health insurance to facilities in the state for vulnerable people for the BHCPF. So we try to clarify that people's expectations when it comes to financing and when we are carrying out advocacy and sensitization. And in the states, apart from the BHCPF, we have also done a lot of work ensuring that all the state health insurance agencies in their laws, they put in provisions for equity funds, so like a matching grant to also cover more vulnerable people than the BHCPF will cover. Now the VGF, like I said, is solely the BHCPF that is fully functional. But even under the BHCPF, there's been a lot of gains. We've successfully disbursed about 63 billion naira as at May this year, since the inception in 2019. Somebody talked about data, and so this is the data that we have. And about 8,000 facilities now receive capitation through the NHIA gateway. Like I mentioned earlier, all the states have their health insurance agencies. All the states, I think Akwa Ibom was the last state to come on board. Rivers is already on board as well. And they also have their structures, and they are implementing the Basic Healthcare Provision Fund. Within the last 1 year alone, 400,000 vulnerable people have been added, bringing it to a total of 2.4 million people who are covered under the Basic Healthcare Provision Fund. Now, still on the VGF and the Basic Healthcare Provision Fund, we pay capitation to the facilities, which is like an advance payment to the hospitals so that they can stock up on drugs and other equipment. So people don't go there and say there's no drug. And then we now pay fee for service for secondary care when they are referred. There has to be an approval before you are referred to a secondary care facility, mostly for maternal conditions, For instance, a woman who is in labor can be referred to a general hospital under the BHCPF if she's an enrollee. So for that, we pay fee for service. Now we have paid a total of 2.5 billion at Q2 2024 for the capitation, and about 212 million for Q2 2024 for fee for service. So quite a lot has gone down to those facilities and care has been provided. Total number of BACPF enrollees who were referred is about 18,000, but we have a lot more accessing primary health care at the primary care level. Now, if you add the enrollees of the NHIA and the state health insurance and the basic care provision fund, and also the private health care, which is being operated by the HMOs, even though some people don't know the difference between private and social health insurance, and we try to do a lot of education around that. For the whole of Nigeria, like I said, under the swap, we have 19.1 million Nigerians who are covered under health insurance. And we know we still have a lot of work to be done, and we are really pushing, because we have really jumped the figure from about 16 million last year to 19 million this year. So almost 3 million in 1 year. Right, so this just shows, I hope this is clear, when we come down or drill down to maternal mortality in Nigeria, somebody mentioned data. We took a sample of 73 tertiary facilities in Nigeria out of about 153, and we noted that over the last 2 years, from their records, we had 236,000 deliveries. But maternal morbidity and mortality has remained a serious issue. Almost 1 in 10 women died. So, still a big problem. Women are still dying. Children are also still dying. And we went back to the delays, which I heard you mention earlier. Delays in leaving your house and going to the facility. Maybe due to lack of awareness of the danger signs. Maybe thinking about the money it will cost. Maybe cultural issues, getting permission, and so on. That's one delay. Getting the transportation, getting the money to even pay for that to get to the hospital is another issue. And then when you get to the facility, some of them do get there. It's another problem. How do they pay? University of Uyo, we are a teaching hospital. We're having a partnership with them. I'll talk more about it later. But they did mention that every once in a while, somebody comes and drops a woman by the gate, knowing that they cannot turn her back. When you ask, are you her relation? They say, no, I was just passing by. I just saw her. She's pregnant. She's bleeding. She has an emergency. And they just leave her there. They can't turn her away. So they take in the women. They treat them. Sometimes they pay out of pocket. But you notice that once the woman starts getting well, the so-called well-wishers who don't know her now become family members and begin to come around and, And so a lot of that was happening. And we noted that, and we had to do something about it. This is another analysis. It's quite small, but I'll explain. The dots going up on the vertical axis, it's the number of maternal deaths. So the higher you go, the more maternal deaths. Going along the x-axis this way, the further you go, the higher the number of deliveries. So you can see those dots up there, more deaths. This way, more deliveries. And some of the facilities that have high deaths, high deliveries, we've identified them, and a lot of them are actually in the north, which I'm sure will not come as a surprise to many of us seated in this room, because that's really where the need is. Some of those dots are FMC Benin Kebbi, ATBU, that's Amadou Bello Teaching Hospital. Abubakar Tafawa Balewa University Teaching Hospital in Bauchi, FMC Gusau, and Aminu Kano Teaching Hospital, and FMC Benin Kudu in Jigawa State. So they have really high maternal mortality and a lot of deliveries, and something just needed to be done. So based on all the data we have collected, the engagements we had with stakeholders, a lot of advocacy was being done. What do we need to do? And it's so much easier when you are on the supply side. We have the demand and the supply side when it comes to healthcare. Supply side is all the staffing, the commodities, the buildings, the infrastructure. Okay, so we're going to train more health workers. Okay, so we're going to get more family planning commodities. We're going to refurbish the health centers. So what about the demand side? When you finish with all that and the women cannot pay for the care, what happens? And then as a demand side agency, what is it that we can do to intervene and make it easier for these women to access care? So based on the discussions with stakeholders, the data that we have generated, and looking at our areas of strength and how we can leverage our partnerships with other stakeholders, came up with 2 different programs focusing on 2 vulnerable groups. Women with obstetric fistulas, they are usually forgotten. A lot of them have been in labor for a long time. Because of the delays, they couldn't get to the facility, and they end up with fistulas. And because of the fistulas, they are now abandoned, they are unproductive, family disowns them, and they have nowhere to go. And we have quite a number of fistula centers around the country. We had the National Obstetric Fistula Centers in Katsina, in Bauchi, in Ebonyi, in Abakaliki, and in Edo. And these are under the Federal Ministry of Health, and they received funding, just their overheads. And they're supposed to provide this treatment free. And so we partnered with them to see how we can improve financial access for these vulnerable women. And I'm happy to tell you that over the past few months that we have partnered with them and scaled up to other hospitals that are also carrying out fistula surgeries, we have been providing or paying for conservative treatment, for surgical treatment, covering transportation as well, family planning services or child spacing services for them as well. We've also added to that when they finish their treatment, we enroll them under the Basic Healthcare Provision Fund through state health insurance agencies to make sure that they can continue their care. And then we are also seeking partnership with Ministry of Women Affairs and other agencies and stakeholders to see how we can further improve the rehabilitation so they can be productive and useful to themselves. 950 women have already benefited just in the last 3-4 months. To tell you the magnitude of the problem. They may be seen as cold cases, but these are really vulnerable women who have nowhere to go if you tell them to leave the facilities and go back. Now, women with obstetric emergencies, especially poor women, these are the women, like I mentioned, the one that was dropped at the gates of UUTH. So we're looking at that third delay. You get to the hospital and you don't have the funding to pay. What happens? So what we are doing is stepping in to guarantee that they will be paid for. So the women, what we are saying is teaching hospitals or hospitals that we are partnering with, and we've started in Kano with AKTH, Aminu Kano Teaching Hospital, Abdullahi Iwase, Murtala Mohammed, and then also with the University of Uyo Teaching Hospital. We've also added a few more. We're in about 10 locations now we have signed MOUs with. And so what we're saying is when the women come, don't wait, don't delay. We are guaranteeing, treat these poor women. But we have a process of identifying them as poor and vulnerable and unable to pay. Once you have treated, we also get them registered because we must have their NIN number for identification and for accountability. You need to know who you are paying for. You need to have their records. So the NIN number is also taken down. Their data is also collected. And then apart from that, we give them access to family planning or child spacing services, and then they are now enrolled into health insurance so that they can continue receiving care. So it's a full package, and we've signed up with about 10 facilities, and we're going to scale that up, hoping to get up to 30 facilities before the end of the year. And this is really important because looking at the conditions listed under there, preeclampsia, hemorrhage, prolonged obstructed labor, sepsis, post-abortion or post-pregnancy loss complications. This is what is killing our women. And under the emergency obstetric care for comprehensive, we know that the cesarean section is part of it. And recently there was a pronouncement, yes, women should have access to cesarean section. So we're scaling this up as quickly as possible. Let these women get access to care. So with these two interventions, we are focusing on the most vulnerable women who have no other option and who would otherwise lose their lives and maybe their children. We are improving financial access to care. We are improving clinical outcomes, ensuring quality, working with the hospitals to ensure that these women get the best of care. Perchance that the women come in so late, or that nothing can be done and we lose these women, we do an audit and determine why these women had to die and see how we can learn from that, go into the communities, do that sensitization, partnering with the hospitals and also the state health insurance agencies and other stakeholders. So we are providing financial access, we're improving clinical outcomes, we're reducing maternal morbidity and also mortality as well. And this is really ongoing. I think we have treated almost about 300 women so far have benefited, and that number is still increasing by the day. We keep getting reports from all across our state offices. And so in a nutshell, what I have tried to do in this presentation, even though it didn't speak to funding for advocacy, is to let you know who we are as NHIA, because there are so many misconceptions out there, which is really important for advocacy, is to let you know what it is that we are doing, especially as it aligns to maternal morbidity and mortality, and also the issue of health promotion. In fact, talking about health promotion, we are working with our media team and some stakeholders with some support from our partners to come up with advocacy materials and tools to change the narrative. Because the truth is that if we have been talking about health insurance for some time and still the level of awareness and sensitization is low, then it means we need to change what we are doing. Either we change the message, or we change the mechanism of delivery, or we change who we are partnering with or something, but we must change something because people need to know, especially now that the economy is the way it is and people are looking for options. So we need to do a lot of work, and we are happy to be here to identify with all the stakeholders in the room, to lend our voice to this, and to say that we are ready and willing to partner with you, especially to crash maternal mortality in Nigeria, and also promote health insurance along the line. So thank you so much for listening. I hope I didn't take up too much time, and I'll be happy to answer any questions you have. I should wait for questions, right?
Thank you so much, Dr. Nenaya. Okay, there are questions, so just hold on to this mic.
Okay, that's right.
Thank you very much, my wonderful presenter. We deliberately inserted the health insurance into this program because we know that in the field we are experiencing a lot of vulnerable people and helpless people, some of them who have to go through cesarean section that is costing 100,000 naira, and they can never afford it. So your last couple of sentences is very important to us. I think you mentioned that you are ready to change the modus of operandi, and you are willing to engage with partners at the state level. The Rotary Reproductive, Maternal and Child Health is working in some states in the country. I will be specific, and I want you to facilitate collaboration in Gombe, Nasarawa, FCT, and Ekiti State. The reason I'm saying that is that we are working in primary health care centers. And technically, no death occurs in primary health care centers because before it occurs, they will transfer either to the secondary facility or to the tertiary facility, or delivery at home and the woman downstairs. When we promote facility deliveries, we are also looking at possibility of upgrading the facility to be able to accommodate those who are going to be sending there. You know, it's a two-edged sword. Yes. You can't be pushing people to facilities that are undergraded, that are not developed. They are not open 24 hours a day. There is no water, there is no light. But we say, okay, we want you to go to facility to go and deliver. That's the campaign. Just like you tell people we want you to use contraceptives, and they go to primary care centers, they can't find the type of contraceptive suitable for them. So we have to attack the issue at both ends. As we are upgrading facilities, we can also continue to campaign for people to come and deliver in the facility. Which role are you going to play? Or do you have any role in the upgrading of primary care facilities? Because I know that 1% of consolidated fund is given to your organization and the National Primary Care Development Agency at the proportion of 60 to 40%. I don't know who gets 60, who gets 40. I mean, you can enlighten us here. We have specific areas where these funds can be targeted. For example, procurement of contraceptives. You'll be surprised that you go to facilities and you can't find contraceptives. At least it's not just to push anything to women. You have to push to them what is suitable for them, because before we administer contraceptives, they go through tests, including blood tests, urine tests, to see what is actually suitable for this lady. And sometimes when they use it for 1 month and they see that it is contrary to their system, doctors can make a change for comfort. So what is the role of the organization in making sure that when clients go to primary care centers, there will be an array of contraceptives as approved by the federal government? I think there are about 14 or 15 now that has been approved. That these 14 or 15 contraceptives will be available there.
Okay, thank you.
I also want to ask whether we need to look at the structure of funding in terms of maternal health in general, and let us prioritize. For instance, you are talking about VVF. VVF has been on in Nigeria for years. And I know that UNFPA is doing quite a lot of work on VVF. It's good to do that, but the concern as of today is that we want to crash maternal deaths in this country. They are caused by preventable causes. And you are the custodian of the most important tool, which is funding, to achieve this purpose. How can you assist us to make sure that this objective is accomplished? Thank you.
Thank you very much, Prof. I think there were like 5 questions in one.
Like 5, okay. DG Kukoye also has a question. So.
Yeah, thank you very much for that brilliant lecture. I'm asking this question because I'm a stakeholder. I'm a private health provider. Yes, we've been talking about universal health coverage, and we know that the health insurance is a veritable tool to achieve that. But I've observed that beyond changing the name from National Health Insurance Scheme to National Health Insurance Authority, nothing much has happened in terms of uptake. Well, from what you said during your lecture, the uptake is still less than 10%, between 5 and 10%. Has there been any critical evaluation of the factors that have prevented this uptake to rise? Because, if we are aiming at universal and we are just talking about 5-10%, we are still a far, far, far distance from it. Thank you very much.
I thought I saw another hand up. Okay.
Thank you very much for coming. I think I've benefited a lot from your talk. However, we're talking advocacy. And I think a good, the people that are supposed to be advocated to have not been advocated to enough. That is the beneficiaries of the insurance, as we will say. Fundamentally, these are examples, practical examples. Clients come to our clinic and say that their money has been taken, given to us, and therefore we must give them health care. And they come on a daily basis. A man with his family, they come in every day. How are you expected to cope? That's number one. So I think we also need advocacy about insurance and what it entails. People that insure their cars, they do not go to the insurance company every month to get the money that they've insured for their cars. Then the other thing is, Prof here has made comments about family planning commodities. It is still, the ones we have are graciously given to us by NGOs as of now. And as of now, where I work in my state, there are no family planning commodities at all. OS. The other thing I want you to consider is government versus private facilities. Government versus private facilities. I think the advocacy should be different. Private facilities pay for everything, including personnel, water, electricity, the rest of them. Government facilities do not, even the staff. Private facilities pay for everything, while government does not pay for many things. And take note that now, the way things are galloping up, electricity has galloped up. Power, so that's power. Diesel has gone up, petrol has gone up, so private facilities are really groaning under the insurance thing as of now. Drug costs have gone up. Suture materials are not made in they have to be imported and they have to be bought. And lastly, the volume of clients coming to the clinics, they break down your facilities, your chairs, break down your toilets, break down everything almost on a weekly basis, and you have to refix them. So, but you people are only thinking of capitation for drugs only. It's not only drugs. There are so many things that are involved that the facilities need some more support. And therefore, please distinguish between government facilities and private facilities. And let me tell you, lastly, that where I work, even in the teaching hospital in Jos, toilets are not working. Patients that come to, it's very sad. Patients that come for chemotherapy, they bring buckets from the home. Yeah, to urinate while they are having, honestly. And sometimes you think it's a light issue. It's not a light issue at all. And sometimes it can be very embarrassing. A patient to bring a bucket, she's on IV fluids. When she feels like urinating, she goes down, they bring a screen, she urinates there, and somebody takes it to the toilet. Look at those other things also. Then you know what to give these facilities for their maintenance. Thank you very much.
Thank you very much, Prof.
Can I? I think I should take
here first.
I think I should take it. Yes.
Doc, I can imagine. You had a very wonderful presentation. But the questions, don't bother. Just take them as low as you can. It's because you excited us. That's why you're having all this reaction. Mine has to do with what the health insurance offers. If you go to the hospitals, if you go into a private hospital, for instance, like I was asking a doctor 2 weeks ago, I happened to stop by in a hospital, but not for a medical treatment. It was like a marketplace. And most of the patients, about 95% of the patients not getting attention are those on HMOs. It will not help our health system. I don't know how your agency will actually intervene in such situations. And it doesn't seem as if people really, those who actually assess it, get, I call it a requisite medical attention or what they hope to get. So I don't know, because it's a regulated sector. I don't know what your agency is doing about that. I'm also aware that when this thing started, there was a law, if I'm right, that for people that employers that have certain number of staff, is it 5? How many? 8. It's compulsory. Okay. It's compulsory in paper. It's not in practice. A lot of people do not have that. So we need to, because now the quest for health has actually increased, and I'm sure you know why. The poverty level is so high. So number of people going to hospitals have actually increased, because the things that make them go to hospital, poor food or no food, poor sanitation and everything. So mine is how, because no matter the interventions we are doing through all these our agencies and all that, we things concerning health issues, they are collective things. They're not something that one person or one agency can actually do alone. But being the supervisory bodies and all that, I'm looking at how you can actually come in to ensure that what is promised is what is gotten. Thank you.
Thank you very much, Ma. I think I might start from, because you said a couple of interesting things. And this is the reason why I said there's a lot of misconception about NHIE. In a perfect system, right, we're just purchasers. In a perfect system, that's why I said there's supply side and there's demand side. Supply side is the infrastructure, the building. It is the staffing. It is the drugs. It's the commodities. It's the equipment. Demand side is just enabling you to pay. If we just face our business alone, our own is the demand side. We enable people to pay. And how do we do that? Simple. We're supposed to, it's health financing. Health insurance is a form of health financing. You pool funds, you mobilize funds rather. And that's, you do all your advocacy, you do all your sensitization, you lobby, you pool the funds from the contributions of people who are working, you gather all those funds together in one basket. When you gather and mobilize that fund, you now pool them together. I mentioned pooling of risks and resources all together. The rich will now subsidize the poor. The healthy will subsidize the sick. So if you have more healthy people, it subsidizes the sick. And then you now purchase from the providers, from the supply side. Now, who owns the teaching hospitals? It's the federal, they're under Federal Ministry of Health. Who owns the PHCs? They're under MPACDA. We do not. Private facilities. In a perfect system, we just come and say, okay, let me see your facilities. Do you have what it takes? Do you have the infrastructure? Do you have the requisite number of staff? Do you have the drugs? Can you supply? We do our checklist. Okay, they meet the requirements. So they are accredited. Then we empanel you. Okay, for you to now work with us, maybe you sign an MOU or a contract. Okay, our patients can now come to you within the system. We do not come and build the infrastructure. We do not fix the toilets. We do not do all that in a perfect system. But however, you cannot just stand and look aside when there are no commodities, there are no drugs, and other things. Because you're supposed to make it easy for people to access care, even those who cannot afford it. So that's point number one. But, people don't really know the difference, and we keep saying that. We are held responsible for everything, but I'm not making excuses. Now, the other thing, Prof, you mentioned that you are in Gombe, Nasarawa, FCT, and Ekiti State. The good thing is that we have a network of state offices with state coordinators at the level of assistant director, deputy director. So it's a very simple thing. If you do maybe an official letter to us, and that can be looked into, we see how we can collaborate, have further discussions, and take it down to the state level. Yes, that's very, very easy to do. And luckily I'm in the DG's office, so no problem. Then BHCPF, I want to clarify that. Now, if you go to the National Health Act, it says that 50% of the, well, at least 1% of consolidated revenue fund, CRF, is for the basic healthcare provision fund, right? And in that act, it says 50% comes to NHIA, 45% goes through MPHCDA, and like that. So then you have the emergency gateway. That's what's in the act. Now, it doesn't go to us to put in our pockets. And, you know, there was a revision. NHIA now gets 48.75%. They had to make provision for NCDC, for public health emergencies. So that's been altered. Again, we don't keep the money. These facilities, these vulnerable people are in the states. So the money is channeled. That's why it's called NHIA Gateway. It's channeled down through the state health insurance to pay facilities for the poor people who have been identified and registered to access care. So it's a gateway for us. What we do is the monitoring, the tracking, the advocacy, both from a programmatic and a financial perspective. In terms of targeting the funds for contraceptive financing, I will say this. The NHIA operational guidelines as it is now, or as it has been over the years, family planning, child spacing, commodities is there as counseling, education. For commodities, because a lot of the partners were already providing that, it was not costed in the NHIA benefit package. But we have been working with a couple of partners to look at TB, HIV, family planning, these areas that are normally covered by partners. But now that we know that funding is dwindling, a lot of them have come to us and say, let's sit down and try and look at the data and do some kind of costing. If we were to integrate TB, HIV, and family planning into the NHIA benefit package, how much would it cost? How much more would people have to pay to afford it? And so those studies need to be done. And then you now look at what is the minimum wage, how many people are earning it? Can we jack up the amount that people are paying and be sure that they will pay? Will we disenfranchise some people? So while that conversation is ongoing, it's not something that you just wake up and say, okay, we have added TB, HIV, family planning. No, we can't do that. They need to go through that process of having those discussions, costing it, doing the studies, even piloting it maybe in one or two places and say, okay, can people afford it if you jack it up? So that conversation is ongoing. Even NACA, we are talking to NACA, NASCAP, and so on. So but contraceptives really are supply side, going back to what I said. Okay, you talked about UNFPA. Yes, they are doing a lot within that space. But then when you talk to donors, you hear a lot of conversation as in the government of Nigeria really begins to need to take ownership. The government of Nigeria needs to begin to do more. We cannot continue to fund these things indefinitely. And now that the government is taking up responsibility, the pushback is now, why are you going there? Because no, these women don't have anybody, and it's a priority from the strategic blueprint, which is why I tied it to that. Crashing maternal morbidity and mortality, reducing physical and financial pain. And these women have both physical and financial pain. What will be best in the long run is totally dealing with those delays, totally ending child marriage so that we even prevent it. And we're hoping that we can do that. Yes, we've treated 950 women in less than 6 months in all over the country. I mean, I want to pray and believe that if we do that to a level, we shouldn't be seeing anybody else. We should be now blocking the pipe and stopping it from happening so that we can focus on emergencies. And that's what we hope for. We don't want to continue doing fistula forever, but it's an intervention that if you really go and see what those women are going through, you will be touched. We were in Abakaliki and it wasn't funny. Young girls, 15, 13, child marriage, they're all leaking urine and stool, and their lives are on hold. Private, somebody mentioned that the uptake is very small. Yes, it looks small because of our population that is large, but you cover 3 million people in 1 year. Well, they said if you don't clap for somebody, you clap for himself. But 3 million people in 1 year, when we were not making progress before, I think it's left for those people, they will know the difference between what they were going through before and what the situation is now. It's not perfect. There's a lot of work to be done. a lot of things that would be better if we were digital, 100%, it would be much better. If we had all the funding that we need, we're still grappling with making sure everybody gets minimum wage. But I can tell you that for most MDAs, ministries, people are supposed to contribute a portion of their salaries, the government will pay a portion. But for most of them, the government is the only one paying. People are not paying. And sometimes the government is actually owing NHIA. There's no cash backing. And we have to wait, okay, we will pay you later, we'll pay you later. And there's really nothing you can do, especially when it becomes a matter of national security. You must provide those services. You cannot just arbitrarily jack up the rates, even though you know that you need to. And I know recently we have increased the tariffs for NHIA, both for registration and also for what we are giving to the facilities. Yes, we have. And we're still doing actuarial review. Once that comes out, we'll review again. But you cannot just wake up and do that. NLC will hit the streets. So there are processes that have to take place, but we are not just sitting and looking. Maybe we are not saying what we should be saying. Maybe we are not getting across to the public. But I can tell you that a lot of work is being done in the background. We designed something around drugs, even though it's a supply side issue, to make drugs available. We're thinking about branding and all that, but those discussions are ongoing to see how drugs can be made available for health insurance at a cheaper rate. And then if you look at the health sector strategic, the blueprint, you can see there's an unlocking value chain pillar. The president there's somebody in charge of the unlocking value chain pillar. There's a national coordinator for that. They already have an executive order to cut down the price of local production of drugs and other materials. That executive order has been signed by Mr. President. So we're looking at that to see, okay, now that those things, there are going to be waivers and so on. So will it come there? But that's not within our purview. We can only work with them. You understand? Okay, beneficiaries of health insurance, people have been paid and they want care. So, health insurance, like I mentioned, when you're doing the costing for health insurance, is based on certain assumptions, right? You assume that a typical family has X number of people. You assume that a typical family will only need to access care X number of times in a year. You assume that inflation will probably not go beyond X% in a year. But we all know what is happening. Inflation is off the charts. People are desperate for care, for what somebody would have just gone across to buy paracetamol for and solve. He now goes to the hospital because he doesn't have that in his pocket. So the hospitals are actually becoming overwhelmed, and we understand that. So people want more care than usual. So it's not peculiar to health insurance. It's a systemic thing. And it's affecting all sectors. That's what I just wanted to say there. Hospitals are like a marketplace, yes. So for that, for the HMOs that delay to give codes, the ones we work with, because it's important to state that, like I mentioned, we're operating a mixed system. Every state has health insurance agencies. FCT has its own health insurance. Sometimes the FCT health insurance enrollees say they're under NHIA, but they're actually under FCT health insurance. They don't know the difference because we use the same facilities. So that's where the integration comes in. If we can integrate and give everybody a unique identifier, and we are all operating the same system, the same benefits package, using the same facilities, that makes it a whole lot easier. But I know when I came in, somebody was saying something about health being on the residual list, so states can, they can legislate on health, and so also the federal. So the way it is now, we have state health insurance, we have federal health insurance. People don't know the difference. We have private health insurance where your risks are assessed. If you have high blood pressure, you pay more. If you have diabetes, you pay more. And you are handled by the HMO 100% end to end. Under NHIA, what the HMO does is the quality assurance and to give code for referral from primary to secondary. But people don't know the difference. As the HMO, are you under private or social? They don't know the difference. So I think for us, we still have our work cut out for us. And like I said, I think it's this week. We are working with, we're getting some support to start developing those media and advocacy tools, trying to reframe the messaging to get it out there correct, trying to deal with some of the misconceptions, maybe make the messaging easy. It might be too complex, so maybe less technical, but we are working on that, and that should be out as soon as possible. We're also updating our guidelines and sanctions to make sure that HMOs that own facilities are dealt with and that they pay back. Let me see. Yes, I think that's what I have. I don't know if I missed anything. Questions? Are there any other questions?
Yeah, there's one hand at the back here.
Thank you very much. I just want to know, where are we now in terms of coverage in percentage for the country?
It was there. I said we moved from 16 million last year to 19.1 million this year. So we've added about 3 million lives. So if you know, because depending on who you ask, the population of Nigeria, some will tell you 200 million, some will tell you 250 million. So depending on who you ask, I will not give you a percentage. I will tell you that it is 19.1 million, and I will allow you to do the mathematics. Thank you.
Any other question?
In the absence of any other question.
Is your hand up, sir? No, okay. I think she deserves a louder round of applause. All right, so on the agenda, come next was plenary session 4, but we realized that many of the things that would have been discussed there have been handled in other sessions, especially in the breakouts, and some were started yesterday, and then in the breakout, I don't think there was any group that didn't talk about religious and traditional leaders when it comes to advocacy. So we decided that it's not necessary to go over that. However, the floor is still open, not just for this presentation now. Perhaps anything regarding advocacy, maternal and child deaths and the likes. The experts are here. Professor Mutihiri is around. Professor Shitu is back. So Prof said I should open up the floor for anyone that has any question, clarification, and the likes. We'll just pass the mic around. Thank you very much, PDG Chukwu.
Well, mine is not actually a question, but a contribution in terms of advocacy. Prof, how is that? Because I've attended a few, or accompanied a few advocacy visits, and you see a lot of mix-up. So I want to advise that, please, if you're on an advocacy, first, keep it simple. Secondly, don't promise what the project cannot offer. Because in the process of trying to make some convictions or get people buy into the project, most times we offer what the project cannot give. And you really do not know who is taking notes in that advocacy visit. You could be actually speaking or talking to or approaching an expert, and he has taken cognizant notice of all what you have promised. And if that project does not offer that, it doesn't portray us very well. So keep it simple and stick to what the concept of the project. I just wanted to add that.
Thank you very much, sir. Any other comments, questions, clarifications? All right, so in order to just tie this up, I mean, for this session, what we should have done regarding traditional and religious leaders would give about 5-7 minutes to the chief imam of the FCT. He's been with us since yesterday, stepped out and he even came back again. So he's supposed to just, give us a little talk regarding how traditional, religious, and community leaders can promote maternal and child health advocacy to prevent maternal deaths. So he would be taking the mic. Please, let's welcome again Professor Mohammed Kabir Adam. He's the Chief Imam of the Abuja National Mosque. He will just give us a talk in about 5-7 minutes regarding that. Please, I think we can appreciate him more than that.
Good afternoon, all. What I'm going to say is going to be 100% religious based. That is my territory. But I have no problem to talk on behalf of all religious leaders because we used to do so in so many forums, so no problem. As we all know, religion is, let me say, is a union that brings all the creatures together to serve the Creator, that is the ultimate Creator, the Almighty Creator, the one and only who creates the entire universe, the only one who gives human the intellect, the intelligence, who allow human beings to discover sciences, to benefit from the science. According to Islam, the issue of taking care of infant started from the pregnancy. In fact, Allah made mention in the Surah Al-Mu'minun, that is chapter 19, chapter I think 20 or 21, that the fertilization take place up to the moment a new baby will be born. So on this period, Quran described that period of that pregnancy as fragile. So it has to be handled with proper care. This is in respect of the life of the infant and the mother, so that they can be taken care of adequately. This is what Quran says in that chapter. Prophet of Islam himself says, the creation of each one of us will be done inside the womb of the mothers. So the mother should be taken care of on this regard, just to protect the infant and the mother herself. Then Quran made mention another word. He says, Hamluhu wa fisaluhu thalathuna shahara, meaning taking the pregnancy, delivery, nursing, that will take at least minimum of 30 good months. 30 good months. Another verse says, nursing the baby will take hawlaini kamilain, 2 good years. That is what? 24 months. That chapter of Quran mentioned 9 months, 9 days, and few hours for the pregnancy. Added to these 24 months, it will give you how many years? Almost 3. So according to the Quranic base, we have the interval between the first and the second birth, at least 3 years. At least. This is what we can call family planning. You can see what we are saying. So this is on the way. So according to this text, you have at least 3 years interval between the child A and B. We are talking about the minimum, not maximum. Maximum has no limit. Yes, in Islam, the mother, the father had to come to agreement on how to take good care of their babies. Yes, marriage is a union of itself. And it is the marriage that produces or that will lead to giving birth legitimately. Yes. So, because of the importance of taking care of the families all together, Islam says you marry the person of your own choice. It didn't say man, it didn't say woman. He said you marry. You can be me and you can be her. Of course, that is what the English says. Only that in Arabic we have difference. But in English, you is you. You woman, you man, yes. So, part of our obligations as the religious leaders in our centers of worship is to call on our worshippers, those who are there to worship with us, in our different centers, be it churches or mosques, is to call on them to take good care of their families, to make sure that they have shoulder the responsibility of all what they have bring in as their own family. Yes, you married a woman. You now take her, or you brought her from her own parent who are taking good care of her before you. Now you take over all that responsibilities. So we always call on men to take their own responsibilities, 100%. Not to bring a wife, deny her so many access in her father's home, and here he will now left her alone to suffer for herself. No. In Islam, as well as Christianity, you have to shoulder the responsibility. This is what we are saying, and that's what we are telling everybody there. And we also know part of faith and believe in oneness of God to take care of what God creates. Allah, in His infinite mercy, create these babies inside the womb of their mothers. So when they were out, it is our responsibility to take good care of them. Give them the shelter. Shelter, it means so many things. Taking care of their food, medicine, housing, clothing, education, all this that are under this word shelter. So our responsibility is very clear, is enlightenment. To enlighten the members of the community to take responsibility that was on them. It is Allah in His infinite mercy say, when you have given a son or daughter, you are going to be account for that son or daughter on the day of resurrection. When you are given a wife, you are going to be accountable for that wife that is under you. You wife, when you got married to somebody, you are going to be accountable for that husband of yours. Have you taken good care of him or not? All this part of way of taking care of the family. So our hope and prayer always to protect our young ones who are coming, because in the absence of our young ones, that means the life will stop at us, and that's what we don't want. We want this life to continue up to the time of the end of the time. Thank you very much.
Thank you very, very much, Prof. Thank you so much for that talk. Now we'll be, you notice that after that, we were supposed to go for lunch, but we consulted and found out that the time we took tea was quite, late into the day, and it'll be best to just take the approach we took yesterday, finish up everything, and then go for lunch. I hope I'm speaking everybody's mind. Am I? I heard plenty of yes, then I heard a few no. I just want to be sure. Yes. The yes have it. Thank you very much, my DG. Okay, so I'll be handing the mic over. If you look at the next thing after the lunch, you see it's a role play exercise. So Mr. Sunday James from TA Connect, and then of course Barrister Mma, the head of health promotion services at the Federal Ministry of Health, and her team. They'll be engaging us in a role play exercise to practice communication with policymakers, traditional leaders, and donors. Please, a round of applause for them as they take the mic and engage us in the role play.
Thank you. So I'm just going to quickly set the tone for the role play, then Barrister and her colleague from the Health Promotion Division will equally re-emphasize how we are going to drive the role play scenario session. So basically, this role play exercise is to practice communication with policymakers, traditional leaders, and donors. And this session objective is actually designed to simulate some kind of real-world scenario where participants can actually practice engaging key stakeholders such as policymakers, traditional leaders, and donors. So this role-playing exercise is particularly effective for building confidence. I want to see how we can test different communication strategies, understand stakeholders' perspectives, among so many other issues. So now this is how we're going to structure it. We have about 4 rows, and just to avoid wasting time, we are going to actually pair us in small groups. The first row there will be the first group. The second row will be the second group, while this row and this row will combine and act as the third group. And we have 3 key scenarios that will be played out and acted out by all of us in the room. And basically, consider this as a safe place where you're going to come and learn, make mistakes, and relearn. So all of us will get into character. To a large extent, it's just like we're going to play, but in playing, there's something we are targeting. So the first scenario, although we are going to share this, before Barrister will emphasize on how we're going to get into character and how we're going to act it out, we have a context that we're providing. And the context is that the maternal mortality rate in the region, which you will contextualize, has been persistently high, and advocacy groups are pushing for increased government investment in healthcare facilities, maternal health education, and even skill-based attendance. So the advocates from each of the groups now, for group 1, we consider this scenario for group 1. The advocate for this group will need to convince a high-ranking health official, within the confine of that group, who we consider as a policymaker, to allocate a portion of the health budget to maternal health programs. So the advocate now will be like a participant who is advocating for increased investment in maternal health programs. That is for group 1. And then the policymaker, typically a health official or a government representative in the room, who controls the health budget. So this is your objective as an advocate. You present a compelling case for why increased funding for maternal health is urgently needed. And then you will highlight the potential positive outcome among so many other things. We're going to give you this scenario, and then you're going to act it out. And the second group are going to engage traditional leaders. And because we don't have enough scenarios to go around, that is why I'm just taking the context again. For the second group that will be engaging a traditional leader, even if we don't have enough traditional leaders in the room, it will be acted out by those of us who get into character. So for them, the context is thus. In a rural community, adolescent girls face high rates of early pregnancies and limited access to reproductive health information. However, traditional beliefs and taboos make it challenging to openly discuss reproductive health. So now the advocate in this group must gain the support of a respected traditional leader. Somebody here will act that out, to introduce culturally sensitive reproductive health education in the community. Your role as an advocate, you want to introduce reproductive health education for adolescents in this community. And as a traditional leader, who is respected in the community, and you have influence over local practices and belief, you also be there to act at your part. You'll be worried about concerns about violation of cultural norms and other issues that will play out because we're acting it. Then the third group, typically this group, your scenario is thus. Child mortality rates in remote communities, you can contextualize it, are high due to lack of access to healthcare facilities, and limited vaccination coverage is also an issue. So now, the advocate is meeting with a foundation or donor representative to request funding for mobile clinic and vaccination programs in these underserved areas. So the advocate is anyone you're going to choose as an advocate here will be positioning themselves as those seeking funding for mobile health clinics and vaccination program. And the donor is actually going to be any foundation representative, even if we don't have them in the room. We have a couple of people who act it out. I mean, that is why it's a role play. So I'll now call on Barrister to further, push on how we're going to act out some of these scenarios.
Thank you very much for your explanations, and also to everyone here. Why we love ourselves, Nigerians, because we are always ready at all times to learn. And that is why we're better than other African countries. And nobody is island of knowledge, and no one is that knows it most or best. Therefore, all of us, we are kids now, and we are going to participate in what he has really directed us and explained. So my staff is going to introduce what we are now going to do. You see her with our advocacy tool that will help us, and we are working with data. That data that is being an emphasis in, that said, we have a lot of, maternal problems in our states, in which we are going to make some governors here. We are going to meet you, that is as advocacy, as policy makers. We are going to meet our traditional rulers who never allowed their church members, or maybe who never believed in family planning, but they believed only on natural method and so on and so forth. So we are going to use the data to prove what will happen. So all of us will be part of it. Thank you very much. Okay, go ahead.
Good afternoon, colleagues. Thank you very much for the opportunity and the privilege. They have said it all, but what I want to add is that we are going to go into the groups now, and we'll be going around to assist each group on how to act it and tell you probably what you need to do. And at the end, each group will come out, to act out what they have agreed in their group. And from there, as we are making inputs, the essence is not to criticism, but we critique, so that we learn, because we learn by practice. Yes. It doesn't take much. Probably say, okay, let some of us come and quickly act, you clap, just like maybe in a conference, whatever. But this is a learning ground. Yes. That is why we said it is better that participants act it out themselves and then correct themselves when need be. There may be no right or no wrong answers, but we are going to make contributions and act with one love. Please, so let's quickly just come together according to the grouping. Yeah. Thank you, everyone.
You can join this table can join here. Quickly, sir, please. Please let us, we don't have time. We don't want our food to get cold, though. So everybody, this place.
Find a way to come together.
Yeah.
So we are acting. Some people can actually stand, you know. We can stand, we can just...
It's just something that will take few minutes. Yeah, you can, that's no problem.
So you are acting. So
yes. Please, ma, you can, would you mind to, that's the circle here. Okay. Yes, this place is good. Yeah, group 3, yes, sir. Yes, ma, this is group 3. This is, hello, please come and join this group. Yes, ma. Yes, sir. Please, you will join, excuse me, you will join where the traditional, you will help us as our traditional ruler, sir. Yes, sir. Yes, sir. That's the in front. That is group 1. Yes, sir. The front one. All right, sir. Traditional. Let's use this one as.
all right, so we have the advocacy group for group 1. No, for group 2, and they are going to be engaging a traditional leader to promote reproductive health education for adolescents. Now the stage is yours.
You didn't greet Chief's wife. You recognize Chief's wife. You're welcome. Welcome to our house.
Thank you. All right.
Bring more seats. Have your seat. Move away. Don't move close to us. Move away.
You don't sit very close to Kabir, you know.
Move away. Don't move.
Every other person pay attention. You are meant to observe and give feedback. You are meant to observe and give feedback. All right. So please, let the show begin.
You're welcome to our house.
Thank you. Good afternoon, sir.
You still didn't greet Kabir's wife.
Good afternoon, ma. Good afternoon, Council of Elders.
Welcome.
We want to respect every protocol here. These are the Advocacy Working Group for Reproductive Health Activities in FCT. Like we said, we wrote later some weeks back to inform you about our coming. So thank you, sir, for giving us the opportunity to be in your palace. We really appreciate that. So this afternoon, I'm here with my team. Because of time, I won't introduce all of them. So we'll go ahead to tell you the reason why we are here. So like we said in the letter that we sent to you, we discovered that adolescents' health education is not properly being captured in the community. We have data that shows that you can see your community, all the adolescent health services are red. And you have a very vibrant health care services in your community, and women are not accessing it, especially the adolescent girls. So we discovered that there are lots of adolescent pregnancy in this community. And then when you look at the rate of criminal abortion, is also high in this community. And that is why we are here this afternoon to dialogue with you and to let you know why we need to sensitize our adolescent girls to be able to know their reproductive rights, and then also assess the facility whenever they have a problem. Like, you know, all the facility staff have been trained on adolescent reproductive health. They are doing the services very well, but we discovered that the adolescents are not accessing the services due to the cultural beliefs and the cultural values that we have in this community. So that is the reason why we are here, to interface with you and to also get your buy-in. Thank you, sir. I don't know whether my colleagues have something to say before you respond, sir. Thank you.
Your Highness, before we came, we sent some prayers to the palace, and we hope you received them. My colleague has already mentioned why we came. Your Highness, we don't want our girls to be falling victims to things that they should know about. Even when they don't know, we want to make sure that even when mistakes happen, they know the right things to do and the right places to go. Your Highness, this me you see here, I have 4 daughters. 4 daughters, Your Highness. I know even one son I know get. And I want all those my daughters to be well, so they can be my own and be taking care of me when I'm old. And we want it to be the same for every woman, every parent in this village. It is part of why we have come. My colleague will say a little bit more, Your Highness.
Thank you.
Your Royal Majesty, thank you for honoring our invitation. Okay, they said I should greet. Kabiyesi. Okay, Olori. Thank you. Welcome. Thank you, sir. So I will just want to add more to what my colleagues have said. We are talking about educating a girl child, the importance. So that's why we are here this afternoon, to convince you, so that our girls in the community can be well educated. So some of the importance, we have to make them have informed choices about their health. Very, very important, and to have control over that. Then also to make them to understand their reproductive health, hygiene, and nutrition. You know, some of our guests nowadays, the way they dressed, at the age of 12, 13, 15, they don't even know whom they are. They don't know what their body is, what they meant to know about their body. You see them, you know, a lot of things they need to be informed, so that they will not fall victim at the early stage of their lives. And also to help to reduce child marriage. An educated child cannot marry at a very early stage. So educating them makes them to know more. They want to at least go further. Thank you, ma. So I believe with this, you will be able to allow the girls in the community to be well educated. Thank you, Kabiyesi.
Thank you very much. Thank you very much. I hope these people have not come to pollute our village.
No, Kabiyesi, you know this has to do with
This their common problem, carrying our girl to the city is going to affect us. And how are we going to explain to our people? You are welcome.
Thank you, Kabiyesi.
How are you?
Thank you.
Thank you very much.
Thank you, sir.
We have listened to you. You are very welcome.
Thank you, sir.
You are very. For the past 5 years, we have not received any visitor from our village. And all these things you tell us that you want to do, it is causing us concern. Because when you begin to educate people, especially our children, you turn them against us. We are leaders in this community. And whatever we say is law. When you come with your, what do you call it now?
Get child education.
Just child education. Our children will no longer listen to us when you teach them this way of doing their own thing. That is number one. Number two is that this reproductive, what did they say it is?
Reproductive health.
Health. This reproductive, we have a traditional method that we have been practicing for the past 200 years that we have been using. And we don't have any problem. If a 13-year-old girl gets pregnant, he go to her husband's house, and the husband will take care of her. She doesn't even need to go to school, because at school, they teach them all kinds of things. They forget about how to take care of the family. They forget everything about our culture. So we have to look at this very carefully. I like what you said, but I am thinking, how am I going to tell my chiefs about this thing they are talking about? How do we convince the other chiefs?
This has to do with children and mothers. Please, they won't corrupt anything. Please, I know them. Women are dying, children are dying for lack of care, and they will help our community. I beg, please.
Okay. Now, what I think we should do is this: you have good idea, and we have to look for a way to convince. I am not the only one in this village. We have to find a way of convincing our other leaders who put us on the throne. Because if we do something that they don't like, they can remove us from this throne. When we talk to them, they may not listen to us. So give me, how do you want me to convince my chiefs that this thing that you are saying we should do, that we should let small girls be using contraceptives, or what you call it, to be using contraceptives, would that not make them promiscuous?
No, sir.
So you have to convince me. How do I, give me a way that I can convince my chiefs that this is the way to go?
Thank you, sir. One of the benefits I mentioned the other time is that when a girl child is educated, there will be delayed marriage. Such a child will not marry at the age of 10, 11, 12. So thereby reducing risk of abortion, risk of vesicovaginal fistula. So these are the things you need to know, sir. Then you help us convince the chiefs of the benefit and the importance of girl child education.
If a girl gets too much education for university and all that, how does he get a husband? How will he get a husband? Eh? They will not come and marry in our village. They will go to another place to go and marry. And this is not something that is good for our village. So we have to think about how we can convince our young people that education is something that is important. My chief and myself, we have agreed in our own that we are going to support you. But you have to be careful. When you come to our village, come to us first, to our palace. Anything you want to do. If you go to the community, before you come to us, anything you see there is your problem. When you come to us, we will be able to call the members of the community, the leaders in the community, introduce you to them properly, and put the matter in their hands. So that together, all of us, yourself, my chiefs, my family, we will all support you.
All right, KBAC.
Thank you very much.
This is a document that has the indication of the death rates and all the effects of lack of health education to the girls in your community. Maybe if you present this to your chiefs, it will convince them, sir.
This education, who is going to pay? Because is it free of charge?
It's free of charge, sir.
It's free?
Yes, sir.
Government will pay?
Will support, sir. Government will support, sir.
Government will support.
Yes, sir.
Will they give them food?
Yes, sir. There is food and everything, sir.
Okay.
Yes, sir.
Thank you very much. We shall look at it. Thank you. You brought
Next
wine.
time you're coming to see the KBAC, you bring basket of some things for the wife.
Thank you very much.
So that I will convince him.
Thank you.
If not, when we go back to bed, I'll turn all these things around. When you're coming to see KBAC, you bring something for the wife.
Thank you very much. Thank you. Thank you.
Please, let's appreciate them. Let's appreciate them. Okay, I think, hello. House, hello. Please, I hope we noted our comments. So that let's quickly take it and then we now make our contributions at the end. All right, so which group is ready to go? Oh yeah, please come up.
Hello, hello. Hi, group 1, please. Quickly.
Barrister, group 3 are already out.
Okay.
Sorry, please.
Wait.
Policy makers, you are the big people. So we'll take you last.
We're going. The
So this group will be convincing a donor to fund health.
Good afternoon, sir.
Initiative.
Thank you very much. The other microphone, please.
No, I know already.
Yes, good afternoon, sir.
Good afternoon.
Yes, sir. Please, we are the one that wrote in that we are coming for the advocacy visit today from Ekiti State. Yes, sir. Thank you very much, sir. So please come in.
Why do you have such a large team following you?
Because we did some research, sir.
Yes.
And so we have representatives from all these units. We have from the family health, we have from a gynecologist, you have our medical statistician, we also have a primary health care worker. This is also consultant, communicationist, and myself, I'm also a doctor, sir.
So why are you here? Why are you here, please?
Oh, thank you very much. We are here because of the problem that we have identified, sir, in this community. Ekiti State, and that is the fact that a lot of our women are dying
is there
from
any
childbirth.
communal crisis?
No, sir, there is no communal crisis, sir. It's what we have observed. That is why we are here, sir.
What is the problem? Have we invited you that we have any problem in our community?
No, sir. We've just come to intimate you.
What problem is that we are not aware of?
We have about 2 or 3, sir. And that's the fact that lots of women are dying from childbirth in the facilities, sir. Hospital facilities.
Just go on, please.
Oh, thank you very much, sir. As I was saying, sir, the basic statistic that will come with is the fact that the United Nations says 552 women are dying per 100,000 childbirths. But in our state, Ekiti State, we found out that it is even more than that, sir. It is 1,000 that is actually dying per 100,000 live births, sir.
When the women will not take herb. When they will
sir,
not take herb.
it is because they are taking the herbs, sir, that is causing the problem. Some of them, their BP will just shoot up at the point of delivery. And that is why, and you know when that happens, by the time the baby is coming out, sir, the blood will just continue to come. And they will not even know how to manage it, sir. That is why, sir.
Well, I think what you have painted is very, very serious.
Yes, sir, it is, sir.
Let me introduce to you. He's one of the directors of our company, and he's also a director. But I have a background of medicine, and
thank you, sir.
I get scared with the statistics that you have just painted now.
Exactly, sir.
And I must say that I'm also impressed by the constitution of your delegation. Many experts there.
Thank you
Please
very
go
much,
on.
sir. All right, sir.
If you can convince us.
Oh, thank you very much, sir. As I have said earlier on, sir, according to WHO, but the research that we have even conducted revealed that 1,000 women are dying per 100,000 live births. And that is why we deem it necessary to pay this advocacy visit and to also plead for your support, sir, at least to alleviate and reduce this, even if it is just by 30%, sir, to reduce this maternal death in this particular community of ours, sir.
How do you think we can come in?
Oh, thank you very much, sir. You can come in finance, especially in about 2 or 3 major ways.
In this economy?
Yes, sir.
Is it not the responsibility of government?
Yes, we've been
to take of our health care?
Thank you very much, sir. We've been to them. They are trying their best, but you know, there is an adage which says that. I'm sorry, pardon me, sir. You know me, when you are sir. Exactly.
Are you sure they're not 419 people?
I'm suspecting.
We are not 419, sir.
The money we gave, you remember the money we gave to one organization that came the last week? We have not seen the effect.
Sir, I promise you will see the effect. It's because the money will be well channeled into 3 major areas. Number 1 is the fact that we have to train our health workers. It is not, you know, some of the women will come to the facility, they came to deliver. And our healthcare facility will just say, shut up your mouth. When you are doing the thing, are you not enjoying it? You are now here disturbing us. But by the time such health worker is trained properly, it is called respective maternal care. You know, we will train the health workers, the nurses, the CHUs, and all health workers generally. Even the doctors will be properly trained on how to talk to our clients and how to speak with them. Oh, sorry, madam. You know, by the time a woman is approaching a health facility, and our women, our CHU, and the nurses, they rush at her to quickly support her, bring her in, welcome her, talk to her gently and nicely. Of course, she will even cooperate. But you know, our people are overwhelmed. First and foremost, we all know that the human resource for health in Nigeria is terribly low. So all these things are the contributing factors. That is the first area, sir. The second area is also to strengthen the quality of care given at these facilities.
Hold on, before you go ahead.
Thank you, sir.
Let me tell you that one of the core values of our organization is integrity and transparency.
Yes, sir.
So in your presentation, you must convince us that
Yes,
if
sir.
we give you this money,
Yes, sir.
it will be judiciously.
Thank you very much, sir.
used, you know.
As I said earlier on, sir, you can see on our team, yes, sitting at the back is the human resource for health expert. And okay, we have Malami Hawa Galadinchi here. She's an expert, she's an accountant. And you can be rest assured that the money will be well utilized and judiciously spent.
Have there been any previous interventions you have done?
Of course, sir. We have worked with Rotary International, and they have helped us. Okay. Thank you. These are
Yes,
reports
can
on
you
what we
go
have
through
done.
this?
Thank you very much, sir.
Well, the father, you mentioned Rotary International.
Thank you, sir.
It's a serious one to us because
Exactly,
we know
sir.
Rotary to be an international organization. And, my directors, I've actually done a background check on their request, and I've confirmed that some of the statistics they present here are probably correct. But then...
That's the scorecard you are looking at.
Oh, okay.
Yes, sir. This thing that they are requesting for us being a corporate organization cannot be done orally. They may have to put up a paper, a letter addressed to the director, managing director, for us to consider at our board meeting.
Yes, sir, we will do that, sir. We will do that, and we will follow up with you as well to ensure that we do the needful. Okay. We'll put a call through, and then we'll personally visit you at your organization.
Our meeting will be coming up this Friday. The earlier you put up the paper, the better.
Thank you very much,
so
sir.
it can be considered.
Thank you very much, sir. We are going to do just that.
And we want to be assured that after releasing the fund to you as requested, you will be able to utilize it effectively, and that there will be opportunity for us to monitor whatever you are doing, so that if you do this one satisfactorily, we can still come up later in future to support you.
We can assure you, sir, that the reports will be forwarded to your office. You will see what we are doing with evidence to back it up, and we'll also publish all of this data, and you will see it. Thank you very much for supporting us. Thank you very much for supporting the cause of Ekiti State.
Come back,
and maternal child health.
Let's just confirm the claim they made about Rotary International. I think with that alone, if Rotary International has partnered with them and they found them worthy, I think that will be something in their favor. Anyway, when they come back, by that time we'll have got enough information about them.
Thank you very much, sir. We are grateful.
Yeah, thank you so
we'll
much.
come back. Thank you.
Please, let's appreciate them. I hope we noted what they did well and what they didn't, what you think there should be improvement. Otherwise, did they do well? But we take our comment at the end of the third group. Please, policymakers, your time starts now.
Sit down. How do we tell us? Where that our Commissioner can sit back. Commissioner. When we're sitting guests. In our delegation. Yes. Commissioner.
Okay, please come. His Excellency is waiting for you. Please come in. You're supposed to. Your Excellency, sir. No, she will finish first. Your Excellency, sir. These are our guests from the Federal Ministry of Health. They initially wrote to us earlier on, and we gave them today, this time. They are here for advocacy visit.
Advocacy visit?
Yes, sir. From the Federal Ministry of Health.
Federal Ministry of Health.
Yes.
Letter came like 2 months ago.
Yes.
2 months ago.
Yes.
All right, I can remember.
And you gave them this time appointment to come. So you're welcome. This is His Excellency, the Executive Governor of Osun State,
Yes, please, just sit.
Governor Adeleke, and his team. You have the Honorable Commissioner of Works and the Commissioner for Special Duty and his Chief of Staff here. So I will hand over to the team to introduce the lead team, to introduce themselves, and then present what they have come with. Thank you very much, sir.
Thank you very much for this great opportunity, Your Excellency. And we are elated to come to your state and to your office this blessed day, because we've been so eager to see you because of the numerous things you've been doing in the state. Every now and then we've been seeing you on the network program, doing one thing or the other, commissioning. We are grateful, sir, and may the Almighty God continue to lift you higher and higher, because your handwork is prevalent in this country. We are grateful to be part of you, sir, and thank you so very much for the opportunity. We are from the Ministry of Health, as the Commissioner for Health have said, and we come with a delegation, so you will hear more from them while we are here, sir. Thank you very much.
Thank you.
His Excellency, sir. Good evening, sir.
You're welcome.
We're here like 2 months ago to see you about the things that is happening in your environment. I know you may not be aware of. Sir, women are dying. Women are dying, children are dying. There is high mortality in your land where you govern. Sir, we have on our own part, we have tried to see how we can do it, but we cannot do it without you, sir. Sir, we want to see you so that you should be able to tell us or help us out of this situation. The women are dying, I say it again. And they are dying for preventive cause of illnesses. Like maternal mortality. A woman died with pregnancy, a pregnancy that's supposed to be a thing of joy. But women are dying during pregnancy. Children are dying. They don't come from postnatal care. They don't attend antenatal clinic. And by this process, they all die. And why? What are they dying for? They are dying for bleeding, which we call postpartum hemorrhage or antepartum hemorrhage.
Come again, post what?
Antepartum or postpartum hemorrhage.
I see.
They bleed. They bleed before birth, or they bleed again after birth. So this can cause many deaths. And sometimes they'll take delivery again. After delivery, they stay at home. They deliver their children in an unkept place, a place that is not sanctified enough for them to have their baby. So this process, you see that their baby will die, the woman too will die on the process. So, sir, this is the reason why we are here. I know you can do it. You have been doing it. We've been seeing you commissioning one health facility to the other, commissioning schools. I know this is just small. You can do it. Our women are dying. Thank you, sir.
Your Excellency, sir, thank you so much for giving us this time. So as my colleague presented this problem, our prayers to you while we are here today is, one, we are praying that you will provide in your budget all the commodities that are needed to tackle this problem. This bleeding that our women are dying from is preventable. There is a new guideline that is recommended by the WHO and even at the national level, that all our women that are given birth, we should use a calibrated drip for them. So our prayer is you will include this calibrated drip in the maternity package for all our women in this state. Another thing is our women are dying from the lack of family planning commodities. So our prayer is you also provide all these modern family planning commodities available in all our facilities in this state. Another thing is a lot of women are dying in the community. And there is a guideline that this woman should be given a drug to prevent bleeding, even if they are delivering at home in the communities. So our prayer is this guideline should be implemented in these states so that all our women should be given misoprostol. And then another problem is we have less skilled birth attendants in our hospitals. You find a hospital without 24-hour coverage with skilled birth attendants. We want the government to employ more skilled birth attendants, either a midwife, a doctor. At least all our facilities should have 24-hour coverage. Another thing is the infrastructures in the facilities. Most of our facilities do not have enough infrastructures. You find that sometimes women are given birth on the floor. So we want infrastructures, delivery beds, and every other thing required to be available in those facilities. The last thing, Your Excellency, is most of our neighboring states that are able to tackle this problem have introduced the pre-maternity care in their states. So we are praying this government, part of the good work you've started, you will introduce this pre-maternity care, in fact, including the cesarean section, because poverty, most of our women are poor and they are not able to afford this care. So we pray that our acts should be implemented. Thank you very much, sir, for your time.
Thank you very much, Honorable Commissioner for Health, Commissioner for Finance, Commissioner for Works. I welcome you, my dear friends, for coming at this time. But I find it extremely difficult to believe. my commissioner for health will bear me out. That we have this kind of painted images around me here. I'm the 17th governor of this state. And my predecessors, I'm very sure of, they took very good care of Ministry of Health and other ministries. You just sang some songs about what we are doing. I have to attend to so many ministries. I've not attended to education finish. I'm talking of water resources. Light is a problem. So even when I have Ocean River by me, I can't dam it. So I'm thinking of all this as a problem that I need to solve. So the commissioner, do you believe what you're saying? This is it's difficult. It's a bitter pill to swallow for me.
Thank you very much, sir. Actually, it's not something that I'm very proud of, but when I saw our scorecard, sir, thank you. This is our scorecard for the year, sir. Sir, everywhere there is red, it means those are the people that have died from childbirth, and those that died even after childbirth, the children that have died.
In my state or their states?
In our state, sir.
In my state? This is incredible.
Yes, sir.
Unbelievable. So, and Commissioner for Finance, PS, is he around now? He will soon join us. We need to take very good record of all these things. I find it difficult to believe that this belongs to my state, but if this is true, then we need immediate intervention. Unfortunately, don't clap yet, until you get to the promised land. Now, this is the 11th month of the year, and you know we do budget every year. We have exhausted virtually everything in our budget, but because you are talking of life here now, life of mothers, somebody gave birth to me, and all of us here, we were all children before. If we went through what this red people, red everywhere, if we went through this, probably we won't be here to do this, what we are doing now. So we will try to see how we can give you immediate intervention.
Thank you, sir.
Intervention in terms of fund. Commissioner for Health, please take note of all this that we are talking about and let your PS work on it. For finance, all commissioners around, please take note so that immediately after now, we go into action and see what we can do. We'll give you some funds initially. When we are budgeting for next year, we assure you that we will increase your funding by a very significant percentage. We are now thinking of how we can build more facilities to reduce this. Ambulances, maybe, TBA will be trained. We'll look for more health workers to join, midwives. Anybody that needs a job, we will definitely do something fast about it so that you can bring this kind of trend down. And give me green.
Yes, sir.
Osun State is a green state. Yes, it should remain green, not red. So, my dear friend, I thank you very much for being here. You can be rest. I will refer you to the Commissioner for Health, his immediate contact, and she will work in conjunction with his counterpart in finance, and special duty will do some part as well. Thank you very much.
Thank you very much, sir.
I wish you safe journey back to your respective states.
We want to appreciate you so much, Your Excellency. And
you can sit down, please. Sit down.
As we have heard the governor talk, is Mr. Talk and Do. What he says, he will do. So I want to rest assure you that as he has promised, he will do it. I actually already have it in our budget for the year 2025, but I can go for a redress and increase and increase and increase. Since I have your word. Thank you very much, Mr. Governor.
Please make sure you entertain them before they go away.
No problem, sir. One word, sir.
Your Excellency, sir, we are very, very grateful for your response towards our request.
Don't mention.
May you live long. May the state live long. Thank you very much. We are grateful and all the commission.
Thank you. Thank you. Thank you. Thank you. I would like to see you immediately after now. Thank you.
Thank you, thank you, thank you. Thank you, the commissioner, the Toknadu. That's it. Thank you very much. Exactly. So that's the end of the role play. Please, you will give us your observations. Give us your observations in that's a group, the group across the groups, and the areas you would like us to improve, so that we will make sure that across all the groups.
From the back. Somebody raise hand. Okay, sir.
Yes, sir. It's working. Give us your observation. Give us your comment.
I can say for all the groups.
Yes. Thank you very much.
So I'd like to thank all the groups for wonderful presentation. So let me start with group 1. So first, for what they did very well, they had a good entrance. They also had a good engagement, and of course the atmosphere was also very good. But what I've noticed is that if you're going to be chief in this society, you carry kola nut. I didn't see that kola nut. Yes, well, yes. So symbolically, they have showed us whether they brought kola nuts. But I don't think Prof got any kola nut when they went there. Oh, you sent an invisible prayer in advance. Okay. Then the second criticism I have is that I felt that too many people spoke in that advocacy visit. And I think that is not the way to go. We should have like one persons that are focal and that will speak for the whole. And then also there was use of technical languages. And I think that we should unpack that more common language so that, you know, people understand exactly what we're talking about, because it's not likely that we're going to meet healthcare providers or health workers, royal fathers or majesties. Then I thought our focus was on girl-child education. But I saw where we're talking about family planning, and so I felt that there was slight distraction. So we should have focused on, you know, advancing girl-child education, because once we do that, the other things will automatically fall in place. So that's for group 1. For group 2, that are looking for funds, I thought that what they didn't do so well is that they didn't say, I think right from the get-go, who they are. I didn't get that clearly. What they do, what they've done in the past. Because if you are going to a funder, it will be good for a funder to understand who you are, what pedigree you have, and what you have done in the past to have achieved some goals. And I didn't also hear them presenting a compelling argument why they should be supported or why they should be funded, except the fact that they said that they've worked with Rotary International. And I also expect that in their presentation, they should have shown the trajectory of how results will be earned. I'm giving you money. I should see how I can follow the money and how money can buy me what you want to do. So show clearly the value for money, transparency, and also a monitoring and evaluation framework. That didn't come clearly from their presentation. For group 3, I enjoyed every bit of that group. Wonderful presentation. But the criticism I have is, one, when you go to see His Excellency the Governor, there are protocol officers that run the protocol. It's not the Honorable Commissioner for Health that will run the protocol. So asking the Honorable Commissioner to do all those protocol things was not right. The protocol office does that. And then I expect that right from the presentation of their advocacy brief, they should have shown data. Even though at the end of the day, they were showing fact sheets, but that should have come a lot earlier. And I also expected that maybe there should have been a small opportunity for a short film, 3 minutes, just to, put some fear of God into His Excellency so that he can understand the challenge that we are facing. Then also, I felt that she also have used some common terms. At one time, His Excellency was asking, that, he was querying the terminology that was used until it was unpacked for him. So I felt that they were too technical at one time. And they had too many asks. You go to an advocacy, I expect that you should have streamlined 1, 2, 3 asks, but they have several asks, and I think that didn't go well. And then lastly, when His Excellency was addressing his commissioners, they rose up. That does not happen. If His Excellency is acknowledging you, he will just say the Honorable Commissioner for Health, Honorable Commissioner for Finance. You don't rise up. It's just protocol that is respected. And then lastly, he talked about Honorable Commissioner for Finance and PS. Now, mostly it's Honorable Commissioner for Finance and the Accountant General that is challenged. Thank you so much for a very good job.
Thank you.
Thank you.
Yes, that's a very good observation. The second person, yeah.
Thank you.
Please, directly to the point.
Yes, and
thank you.
Surely all the presentations were very, very good. But I have only one criticism with group 1. And I think it was slightly mentioned by the first speaker.
Yes.
I believe the setting was a village setting. And a village is where you have local people, more or less. So the kind of English being spoken there were more of Queen's English. Not for that level of people who are in that community. And even at times, there are local dialects. Yes. You want to catch their attention. There are people that should speak the language of that environment. If it's a Igbo language, if it's a Hausa language, so it gets down well with the village people, other than all the English that were being spoken. Even the chief himself, the Oba, was now speaking Queen's English.
Thank you, ma'am.
Thank you.
Thank you very much.
Thank you. This observation, coincidentally, is for my group. I just rose from a gender streaming exercise in Geneva 2 weeks ago. And when you're going to visit, I kept trying to throw it out, but even my group didn't catch it. You want to go and visit a traditional ruler and the wife is there. You ignore the wife, you will never get anything done. You will never. Every time you're talking, try to refer, Olori, now, women now. You try to carry her along, So the KBC won't do a hard work trying to convince the people, because this is the person he's going to pass the night with and all that. So if you don't treat her nicely, and you've also come to talk about women and the girl child and the children, and you just keep talking to the KBC and you ignore the wife, I will even start wondering whether you came to take my husband, and you will never succeed. So please, let us be conscious of that. Gender is key in advocacy. Thank you.
Thank you very much. Thank you. Okay, ma.
Well, all the groups have done well, and I give kudos to all of them.
Exactly.
But then I just want to say something about what our peers said. Well, protocols may differ from states. What he described is not what happens in our states. the moment the protocol officer introduced you to the office of the governor, the commissioner for health is an executive council member. She or he has a direct contact with the boss. At that particular time, the protocol officers no longer, so ordinarily, they can't come into the office of Oga, except if he says, please come in and do something like telling them to give what he said he was going to give to the
Thank
group.
you. Thank you. Thank you very much.
Any other contribution?
Any other contribution? We just take only one. One more. Thank you very much.
Just to comment, all the groups, as the other speakers have spoken, the only thing I want to add is that what's the decision maker that you are going to? If it's a chief, you talk slowly and gently and bring up the points. Because I noticed at one point in time, the talking was too fast and it was being dramatized. No, that doesn't happen in those palaces. So, and I think that is a point that I have to make. Only one. Please talk steadily and gently and pass your points. Thank you.
Thank you, sir. Thank you very much. All right. One of us has a contribution to make, so we allow her. Thank you very much.
Thank you, everyone. If I'm asked to score you, I'll give all of you minimum of 80%, sincerely speaking. First and foremost, you were not told before today. People rehearsed here, and it's not easy even to stand here. Sometimes you even forget what you plan to come and do. Sincerely speaking, you all did well. Yes. But there are some exceptional, I will never fail to point out. The last group policy maker, you said that if you want to get a monkey, you behave like a monkey. Their entrance was excellent. They started by appreciating what the governor is doing before romancing his ego. And then you demand for more, isn't it? I'm saying it because, remember, there's no scoring here. But I'm saying it so that what will work for us tomorrow. Remember, initially I said no right, no wrong. The essence is for us to learn what will happen when we live here. I really appreciated that one, and it's important. This has been said, but I want to reiterate it because of the importance, the use of jargon. I noted it for first group, talked about VVF. It's even traditional group that started, I think so. And they started by telling them VVF, viscovaginal fistula, to a traditional ruler. And there's a comment the initial speaker made. He said, sorry, it was she. She said, with this, I hope you'll be able to allow our girls to go to school. If I were the traditional ruler, and at that time I was sent out of my palace, am I the one holding them not to go to school?
No.
It's not me now.
It's
so
the
what
culture.
You now said after explaining this, you should be able to be an advocate and help us to change the culture that makes our girl children not to go to school, rather embrace early marriage. And we should be able to, like that VVF, actually had it in mind that should come out. But rather than calling it VVF, you should explain to him, he saw women that leak urine as a result of giving giving birth to a child when the pelvic is not matured. That is more we wish to see if we do not address the problem now, instead of that big grammar. Then, generally, to all the groups, I think I had one group mention that they had a media. Did any group go with a media? No group went with a media. You can never go for advocacy to that level, high targeted advocacy without a media. You know that policymakers at any level, traditional, donors, they want to see themselves on television. And most often that it's difficult for them to swallow their words back after they have pushed it up to the air. Radio has carried it. If he carried that governor said he would do that. You want to do it because you hold him by it. Possibly video him and show him back. You say you will do this. Please don't go for advocacy without media. And to some of them that made a promise, I expected to ask for a follow-up. When can we come back, sir? Who do we meet since you say you will do this for us, sir? Although I think governor tried it. And sorry, I hope I'm not talking much. No. Please forgive me. Okay. They have talked about that other one. For the group 2, the lead advocate dominated everything. He dominated and talk. And we were so in a hurry to dish. Are we Oliver Twist? I know that we need more. But it's better we go for a particular health issue or 2 and request. Like the last group, they did well. But they were, give me this, give me that, give me. And at the end, I'm sure even the governor was confused. He only talked about, okay, at least he was able to see the red about maternal death. He said, my state on your own state. And the promise was what he has to do there. So every other thing we ignored because there were quite many. Even the Bible said that if you do not have a gateway how you ask in a miss, isn't it? So we have a target on what you want to ask. And I want to end this by saying that it is excellent presentation.
Thank you very much.
I want to do an exercise.
Thank you.
So please, with your permission, ma.
Yes.
I just want to end this section and drop this microphone by begging excellent faces here to please be on your feet. Please. To be on our feet. 1 minute. So I want us to do 1 minute energizer. 1 minute energizer. We know it. But the only way, the difference is how we are going to end it now. We know. All of us know watermelon, right? Do we know it? Okay.
We know it.
This group was singing for me. Watermelon, watermelon. This one says papaya, papaya, banana, 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 banana. We now turn it. It's all of them. When we cut 3 of them, it's all fruit salad. So we mix it, right? Fruit salad, fruit salad. So now the way we mix it is where the exercise is. And we are going to mix. Promise me you mix it. So let's go. Watermelon, watermelon, banana, 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 banana.
Melon, watermelon, banana, banana, papaya, 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 papaya.
Let's give ourselves a thunder clap. No, we do it together. Let's give ourselves a thunder clap. Another one. Another bigger one. A greater one. I really appreciate you all. God bless you. Thank you.
Thank you.
Thank you very much. We are very, very happy. This group is available, and we are passing the message to reduce maternal mortality and child death in our society. So wherever you are doing your program, the health promotion of Federal Ministry of Health is very much available to use other medium to pass our message or pass our objectives. And this group is very much available. Thank you very much.
Thank you,
God bless you.
Thank you, Barrister. So just a few reflection on what just transpired before I hand over the microphone, mostly on the positives. Great work, everyone. Great work. I just took time to jot a couple of things because I was quite busy and I don't want to forget. We saw clearly You know, we saw understanding of stakeholders' priorities from all of the engagements here today. And we also saw clearly that success often comes when advocates directly address their stakeholders' core concerns. You know, for those who were addressing the policymakers, whether it is budget constraint, for those speaking with the traditional leaders, we're talking about cultural alignments and issues of transparency with the donors. That came out very strongly, and we appreciate all of the groups for excellent work. Empathy and respectful dialogue, we also saw that, you know, except for the complaint by the wife of the traditional leader, as much as possible, we must appeal to people's ego, appeal to some kind of sentiments to help us, you know, with our advocacy effort. But those who actually listened closely and responded with empathy in all of those groups, we could see that, you know, the group that engaged the traditional leaders, you made significant progress, because I saw, sorry about that, we actually saw something about respecting cultural values, and that actually goes a long way. And the third one is being data-driven, you know, and clear on impact. Those that actually engaged with the donors were very, very clear on impact, and they had their data, you know, handy. And that actually went a long way, because with donors and policymakers, having a clear data, you know, or anticipated outcome to strengthen your advocacy effort is equally very critical. So basically, you know, before we end this session, just take a moment, because some of us will just see it as drama, as just an ordinary role play, but no. Take a moment to reflect and think about how you can apply what you've practiced today, you know, from this session for your real advocacy effort. That is very critical. And critical also is that, what will you do differently next time? You know, you've heard from a lot of people, the critiques and all of that. What will you do differently when you are faced with a real life scenario? This is just a role play. So what will you do differently from what we've seen today? These are some of those things that should be ringing in our heads at this point. And how can you better prepare your data or your stories when you are engaging with your target audience? You know, and as much as possible, we didn't see any human interest story. When we're talking about issues around PPH and women dying from bleeding, no one is giving a face to some of those things, saying, oh, one Hajara from one community in Yobe State, you know, this happened and died as a result of. I mean, put a human face to all of this, and that actually can drive your advocacy effort home. So we should continue to practice some of these skills. It's very important. I want to thank you all for your active participation and your openness as well. A lot of big men in the room, and we brought you here to come and act drama. You know, I was initially scared, how do I bring all of these people to come and act drama? But I mean, it actually went very well, and we thank you for that. So just remember this, that advocacy is an ongoing effort. So the more we adapt and connect with our stakeholders, the more impactful we can actually be in our advocacy effort. So let's keep all of this insight we've gained today, let's keep it with us as we work to strengthen RMCH effort across our communities. Thank you, everyone. Please put your hands together for yourselves. Thank you.
Thank you very, very much, distinguished ladies and gentlemen. There's Hollywood, there's Bollywood, there's Kannywood. What we call this one? Sorry, sir? Rotary. So let's put our hands together for Rotary. We did a very fantastic job. Without any further ado, if you look at the last item for today, you'd see that it's supposed to be just a recap of what we learned, action plans and the likes, and you see that that's supposed to be handled by TA Connect. So I'll hand over back the mic to Mr. Sunday James. He's from TA Connect. He'll do that, and then I'll just come to make a few announcements, and that will be all. Thank you very much.
All right, no complaints. So we're going to just summarize some of the key points from today's session. Professor Shitu's presentation around the core of advocacy. You know, some of those key take home is that active support of an idea, cause, or proposal, especially the act of pleading or arguing for something, is very important. He also mentioned that advocacy is not a one-off engagement, that it has to be continuous and it has to be done at all levels. Professor Shitu also mentioned that advocacy is meant to protect the self-interest, to educate and provide public awareness and promote a cause via public and private events. He also mentioned that in the events where all stakeholders are not properly mapped, the advocacy efforts may lead to waste, and this may also entail starting over again. And this will also entail more resources being depleted in this expedition. And he mentioned that knowledge of how state institutions work, understanding political contexts, availability of human and economic resources, among others, are some of the factors that will make advocacy successful. And that is very important. It came out strongly. And he mentioned that there are 8 steps to planning a successful advocacy, which includes identify and analyze the problem, formulate the proposal, analyze the decision-making space, analyze channels of influence, do a SWOT analysis, design advocacy strategies, develop and actively plan, and carry out continuous advocacy. And that also came out strongly. Now, Dr. Nnenaya Kalu Ume, representing the DGNHIA, during her presentation, some of the take-home, that their goal basically is to save lives, to reduce both physical and financial pain, and produce health for all Nigerians. And she also mentioned that the outcome they want to achieve include the improvement in mortality and morbidity rates, drop in of out-of-pocket expenditure by patients, and reduction in difference in health outcome between different income quartile. She also mentioned that over the last 2 years, over 236,000 deliveries were made in 73 out of 153 tertiary facilities nationwide, and maternal morbidity has remained a pressing issue. And although they have improved coverage from 16.1 million to 19.1 million, that the 7 strategic pillars for NHIA from the FMO, from the Federal Ministry of Health's vision include coverage, equity, quality of care, market efficiency, drive citizen-centered engagement, use data and technology to improve care quality and availability, optimize organizational health and structure. And so far, they are providing financial access as best as they can, towards reducing morbidity and improving outcomes. Then we had the chief imam of the Abuja National Mosque, who actually emphasized on the importance and the influence of religious leaders in promoting access to sexual and reproductive health services overall. He said that both major religions do not support giving birth to children mindlessly without having the means to take care of them. And for the role play, we already shared all the key points and reflections. And once again, I want to thank everyone for their time. And this is where we draw the curtain on this session as I hand over the microphone to the anchor.
Thank you very much for that. So we're done for today. The time is 4:24. We're done for today.